Hello and welcome to our kidney cancer patient and caregiver symposium. This is brought to you today by Rush University Medical Center and the Judy Nicholson Kidney Cancer Foundation. I hope we have an exciting and informative agenda for you today. We've decided to touch on a number of topics that I think patients and their family members can appreciate with regards to the management of their kidney cancer. To run through our agenda, we're going to begin our program today with a discussion on the pathology of renal neoplasms. We are then going to talk about a number of different surgical approaches to renal masses. We're going to have one discussion about active surveillance of renal masses, so who can be monitored without requiring surgery. And we're going to have a second talk then on the robotic surgical approaches to renal masses. We then have a presentation on the surgical management of metastatic renal cell carcinoma, specifically to bone. It can be a challenging area where this disease spreads to and often requires innovative surgical management. And one of our orthopedic oncology colleagues will make that presentation. Then, after a short break, we'll have a discussion of image-guided radiosurgery or stereotactic body radiation of the kidney cancer metastases. Often these can present as only one or two sites of disease, and they can be controlled adequately with radiation therapy in lieu of starting systemic therapy. And then I'll be back to share with you a number of approaches for the first-line treatment of advanced clear cell kidney cancers. One of my urologic oncology colleagues, Dr. Alan Tan, will address adjuvant therapy as well as novel emerging strategies in the relapse setting for advanced kidney cancer with a focus on clinical trials. And then we have several presentations on the impact of this disease on both patients and family members. We have a presentation on coping and resilience in cancer survivorship, and we'll close the presentations with a discussion on the role for supporting patients and families utilizing palliative care experts. We'll then be back for a panel discussion with a number of the presenters who will be able to address some of your questions. So thank you for coming. I hope you have an interesting and informative morning with us. Thank you.
Hi, I'm Linda Ostosky, president of the Judy Nicholson Kidney Cancer Foundation. We are here today to give hope to those battling kidney cancer. Yes, it is a battle, but you are all winners. Today, we have some wonderful speakers who will give you the latest information. They will inspire you and give you hope. I would suggest you go to your support Facebook page afterwards and talk to each other, because that is what it is all about, people helping people. I would like to thank Rush University for teaming with us today, and also thank you for the speakers who are giving up their time. But most of all, I want to thank those who are battling kidney cancer and their caregivers for coming. I truly hope you get strength and inspiration from today's talks. So let's begin.
Good morning. My name is Dr. Park. I am a pathologist at Rush University Medical Center. I'm really happy to give this talk to you today. I'm going to be talking about the pathology of some renal neoplasms and go over the important stuff of your pathology report. So the title of my presentation today is Pathology of Renal Neoplasms, a guide to understanding your pathology report and an overview of the most common renal tumors. So some of the goals and objectives of my talk today is to explain the role of pathology, what happens after the surgeon takes your specimen out and it goes to the pathology lab, what do we do to process and analyze the tumor, and then I will describe some information found in the pathology report, especially talking about the most recent tumor summary available from the CAP, which is the College of American Pathologists, that's our governing body. I will mention some of the renal neoplasms listed in the current WHO book, that's the World Health Organization. And then I will review some of the most common renal neoplasms, including oncocytoma, renal cell carcinoma clear cell type, renal cell carcinoma papillary type, and renal cell carcinoma chromophobe type. So some steps that occur in the pathology lab. After your surgeon removes a specimen, it comes to us in the pathology lab. So the first thing we do is accession the case. That means that we assign it a pathology number for our database, and we make sure that all the labels are correct. We make sure the patient identifiers are correct, and everything's in order. Once we have it accessioned, it goes to the person who will be grossing the specimen. That person is usually a pathology assistant or a resident or a fellow. When we get the specimen, the first thing we do is first make sure that we have the correct identification. Then we weigh and measure the specimen. After we do that, we describe the gross appearance and measure the relevant parts that we see. This includes things like the ureter, the attached fat, adrenal gland, renal arteries and veins. And after we do that, then we start slicing into the specimen to find the tumors. So here are some gross pictures of the kidney when we receive it in the lab. You can see that it's entirely covered with fat, and that's what we see. We always have to measure it and weigh it as soon as we get it. This is the flip side of it, and you can see that there's a ureter coming off of it, which has a little clamp on it. So this is what the specimen will look like when we initially get it in the lab. After we do these steps, then we take measurements of the tumor itself as soon as we find it. We discover what the distances are to the margins and important structures. We determine the extent of invasion and the relation to the other tumors, if there are any. After we do that and do all of these necessary steps, then we can take sections of the specimen and submit it for processing. The material then goes into our processor. It's a machine that works overnight, and it gets properly fixed and then embedded into wax, into paraffin wax. Then what we can do with the blocks, once those are ready, is that we cut it into thin slices, just a few microns in thickness, and then put it on a slide. After we have the slides ready, we can stain them with hematoxylin and eosin. That's the type of stain that we use. We then cover slip it and give it to the pathologist for analysis. So as I mentioned before, we cut into the specimen, and here we can see the tumor very easily right here up at top. This part at the bottom and off to the side is the normal kidney. So this is the tumor replacing the top half of the kidney. Then what we do is we cut relevant sections, and here this is sections of the margins that we need to take, and we put them into a cassette for processing. So after all this is done and the slides are ready, they can go to the pathologist. So what is the role of the pathologist? Basically, we oversee all of the steps for handling, processing, and preparing the specimen. We make sure all the grossing is done correctly. And then once we get all the slides, we look at all of them under the microscope. So we do a very thorough microscopic examination. We determine the diagnosis after we review everything, and we also look for any relevant features necessary for the clinicians. After we're done with that, we formulate a clear and informative pathology report. So in your report, this is what you should expect to see. If it's a benign lesion, they're usually much shorter, the reports. You need to have the final diagnosis. Obviously, you need to know what it is. And you may include additional information such as size and margin status if it was completely removed. Now, if it's a malignant tumor, we need to have a lot more information in that report. So you need to include things like the diagnosis, obviously. We need to know what it is. We need to know how big it is, so the size. The extent of invasion, so what exactly is involved with this tumor process. If the margins are negative, to know if it's completely resected. The lymph node status, if applicable, if lymph nodes were removed. And then the stage in CAP tumor summary, and I'll show you an example of that pretty soon. Also, any additional pertinent information, such as grade of the tumor, if there's any necrosis, so if any part of the tumor is dying, if we used any immunohistochemical stains, and I'll show you an example of that later on. So all of that information needs to be in your pathology report. So here's what the CAP tumor summary looks like. So CAP, again, stands for College of American Pathologists. They provide these protocols so that we can have information that's relevant and in an orderly fashion given to the clinicians. So included in the tumor summary is information such as the type of procedure. Is it a partial or a total radical nephrectomy? The tumor site, so is it on the right side, left side, is it bilateral? The tumor size, how big is it, again? Tumor focality, so is it just one or is it multifocal? The histologic type, so exactly what it is. If there are any worrisome aggressive features, such as sarcomatoid or rhabdoid features, which basically means it's more aggressive. The grade, which for our grading system goes from 1 to 4, 1 being the lowest grade and 4 being the highest grade. If there is any tumor necrosis present, the amount of tumor, how far does it extend? Does it go to things like the vessels, renal pelvis, the fat, Gerotis fascia, adrenal gland, things like that. Margin status, of course, I mentioned that before. We want to make sure that the tumor is entirely removed. We need to know if the lymph nodes are positive, if any were taken out, and then the overall stage. So this is a big list of all the different types of tumors that can happen in the kidney. This is the current WHO, that's World Health Organization, classification of renal tumors. You can see there are quite a few of them on the list. This includes both benign and malignant neoplasms. I'm not going to be talking about all of them. I'll just be talking about some of the more common ones we see here at Rush. So the ones highlighted in red are the ones that I will be discussing. So oncocytoma is a benign renal epithelial neoplasm. Is the most common benign one that we see. It accounts for about 5 to 9% of all renal neoplasms. The male to female ratio is about 2 to 1, so twice as common in men than women. The average range of age for people to get this tumor is 24 to 91 years old, so you can pretty much get it at any age. On gross appearance, so when we get it in the histology lab and we cut it open, we see that is a well-circumscribed tumor, so we can see the borders really well. It's usually this rich mahogany brown color, can also be tan in color. And there's usually a central stellate scar, so a star-like scar is present right in the middle. Under the microscope, what we see are these solid nests of cells, of tumor cells, and they're often these larger eosinophilic cells, so that is just a fancy word for pink. They have a lot of granular cytoplasm, which I'll show you in a bit, round nuclei with visible nucleoli. Some things we can do to identify it, because sometimes it looks like other tumors. What we can do is we can do some stains. And these types of benign tumors tend to be positive for CD117 and pancytokeratin. They'll be negative for stains such as CK7, vimentin, and Hales colloidal iron. And I'll show you some of these stains in a bit. So here's an image of a bisected kidney, and right in the middle, this dark brown color, that is the tumor itself, that is an oncocytoma. You can see that's really well defined. You can see it compared to the fat around, and it's this rich brown color. Now, this is what we see under the microscope. This is on the left on lower power. On the right, it's higher power. You can see on lower power, it's this bright pink color all throughout. And then on higher power, we see these rounded nests of cells composed of these relatively uniform appearing cells. They have abundant pink granular cytoplasm, as I mentioned before, nice round nuclei that look relatively uniform and relatively bland in appearance. So this is an oncocytoma. Now, as I mentioned before, sometimes we use immunohistochemical stains to try to help us with the diagnosis. This basically stains different parts of the cell's colors so that we know if it's positive or negative. In this example, this stain is CD117, and it's staining the membrane. So the cell membranes are outlined with this brown color, so we know it's positive. And this is what we see in an oncocytoma. Now, the most common malignant renal cell neoplasm is clear cell renal cell carcinoma. It accounts for 65 to 70% of all renal cancers. For the male to female ratio, it's about 1.5 to 1, and it's most common in the 6th or 7th decade of life. It can be associated with genetic syndromes such as von Hippel-Lindau, but not necessarily always the case. It has a worse prognosis than the other two malignant neoplasms that I'm going to discuss later, which are papillary and chromophobe renal cell carcinoma. On gross appearance, what we see when we cut it open, we usually see it's this nice round globular tumor. It is usually this golden yellow color, and it has areas of hemorrhage, so areas of bleeding and areas of necrosis too. Under the microscope, what we'll see are nests of tumor cells with lots of clear, vacuolated looking cytoplasm, and you can see the cell membranes really well. And it's usually surrounded by a network of thin walled blood vessels. And I'll show you a picture of that in a bit. We can do some immunohistochemical stains if we need some help with the diagnosis. And these tumors tend to be positive for CA9, Vimentin, and CD10. They tend to be negative for CK7 and CD117, and also Amicar. It's like on gross appearance. So again, this is a bisected kidney. This is a normal kidney at the bottom, and up at top, that is the tumor itself. You can see the nice yellowish kind of orangish color, and there's a little bit of bleeding going on. So this is the tumor itself. Here it is on low power on the left and a higher power on the right. On lower power, you can see that it is remarkably clear, especially compared to the previous example I showed you, which looked really pink. And then on higher power, you see that there's a lot of this cleared out cytoplasm. We have these nuclei in the middle with prominent nucleoli. That's the dot right in the middle of the nucleus. So another malignant cancer, that's the second most common renal carcinoma, is papillary renal cell carcinoma. It accounts for about 18.5%. In adults, it has about the same age and gender distribution as clear cell renal cell carcinoma. When we see it in the lab and we cut it in half, we see a nice, well-circumscribed, friable tumor. In other words, it tends to fall apart a little bit. Under the microscope, what we see are there are two different types of papillary renal cell carcinoma. There's type 1 and type 2. Depending on which type it is, it will look a little different under the microscope. If it's type 1, we still see papillary structures, which I will show you in a bit, but they have a nice single layer of tumor cells with just a little bit of scant pale cytoplasm around the fibrovascular core, and we tend to see a lot of foamy macrophages. Now, type 2 is the uglier version. Again, we still see the papillary structures. However, the tumor cells tend to be pseudostratified, so they line up funny, and they're crowded together. They have more eosinophilic cytoplasm, so again, that pink granular cytoplasm, and they tend to have a higher grade nuclei, so the nuclei are a bit uglier. If we need to do stains, some immunohistochemical stains are positive, are CK7 and Amicar. So here's an example of half of the kidney. You can see it's cut in half here. This part is the normal kidney. And then this part right here is the tumor. Again, it's more of a brownish, reddish color with some bleeding in the middle. This is an example of the tumor itself. Under the microscope, you can see these finger-like projections right here. Some of them are branching, and they have a blood vessel in the middle. This is an example of papillary structure, papillary architecture. And this is an example of type 2. You can see that the cytoplasm is more of a pink color, and it's lined up. So this is type 2 papillary renal cell carcinoma. Here in this example for this patient, it actually did metastasize to a lymph node. So on the periphery here, this is part of the lymph node that remains, but all the rest of it is replaced by the papillary renal cell carcinoma. The last tumor that I'm going to describe for you today is called chromophobe renal cell carcinoma. It is the third most common renal cell carcinoma, about 5 to 7%. When you see it under the microscope, it actually looks a lot like oncocytoma, which, as we described before, is a benign type of renal neoplasm. So we really need to make sure that we get the diagnosis right, since chromophobe renal cell carcinoma is malignant. On gross description, on what we see grossly, we tend to see a well-circumscribed tanto brown in color type of lesion. It tends to have a central scar as well. Under the microscope, we'll see solid sheets of tumor cells with this pale pink. Instead of being really granular, sometimes it's more of a pale pink type of cytoplasm. The nuclei tend to be darker and wrinkled and might have a little bit of clearing around it, which we call a perinuclear halo. And they also tend to have distinct cell membranes that we can see really well under the microscope. If we need to do stains, which we usually do need to do stains because it does resemble a benign neoplasm, it tends to be positive for CK7, CD117, and Hales colloidal iron, and it tends to be negative for Amicar and Vimentin. So here's an example of chromophobe renal cell carcinoma. You can see the tumor is up at top. It's really large. This is the normal kidney below right here. You see the ureter coming off of it. This is what it looks like under the microscope. You can see a lot of these big, pale, pink kind of cells. You can see the borders really well, which means you can see the cell membrane really well, and they're arranged in these nests. And some of the nuclei are more on the dark side. They tend to be a little wrinkled, and they look a bit uglier than what we saw with oncocytoma. So that's how you can tell it differently based on morphology. But of course, if you need some help to make the diagnosis, one of the stains you can do is called Hales colloidal iron. And when it's positive, it turns this bright blue color, and you can see it's positive in this example. Now, this is my list of references. So that concludes my talk for today. Thank you so much for allowing me to participate in this symposium.
Thanks for everyone tuning in here. I want to thank the Judy Nicholson Kidney Cancer Foundation for allowing me the opportunity to speak with patients and caregivers of patients with kidney cancer. My name is Alexander Chow. I am an assistant professor of urology and the director of robotic urologic surgery at Rush University Medical Center in Chicago. And it's my pleasure today to talk about active surveillance of small renal masses. So I want to go over some terminology. What is a small renal mass? So a small renal mass is an incidentally identified tumor on the kidney that measures 4 centimeters or less. And by definition, it is locally confined to the kidney. And active surveillance is the concept of watching a potential cancer without treatment, but with the intention to intervene in the future if the tumor progresses. And active surveillance is something that we as urologists are very common with prostate cancer, and also should be applied to small renal tumors as well. And we call these tumors and masses and not cancer. And that's because we are not sure if these tumors that are identified on kidneys are actually cancers. And in fact, the data on kidney cancer shows that size is important when it comes to the probability of it being cancer. So as you can see here in the chart, as the size of the kidney tumor gets larger and larger, the chance of it being a cancer increases. And the chance of it spreading outside the kidney also increases. So for the purpose of this talk, we are talking about small renal masses, tumors that are 4 centimeters or less that have a about 75–80% chance of it being a kidney cancer, but less than 2% chance of spreading outside of the kidney. This data is from the SEER database, national database on cancer prevalence. And owing to the introduction of new imaging technology like CT scans, MRIs, and ultrasound, over the last few decades, we've incidentally detected more and more of these small renal masses, kidney tumors that measures between 2 to 4 centimeters. And corresponding to this increased incidence of kidney tumors, we've also been operating more on these kidney tumors as well. So this looks like the same exact graph, but in fact is different. And this shows that there are more surgeries done for tumors that are between 2 to 4 centimeters in size within the last few decades. And one would think that if we're picking up more tumors and we're operating on more tumors, we are helping out the patients and should be decreasing the incidence of death as it relates to kidney tumors. Well, that's actually not true. And here you can see as the incidence of kidney cancer rises and thus treated, there has been no impact over the last few decades when it comes to mortality from kidney cancer itself. So are we really helping these patients out? And if you look at tumors that are taken out surgically, about 20 to 40%, depending on the literature they look at, are considered benign tumors. So these are tumors that do not have potential to spread outside the kidney. And of those tumors that are cancer, a majority of them, 70 to 80% of them, are considered low grade and early stage, slow growing tumors that may not have any impact on your overall survival. And this translates to a big economic impact when we're operating on tumors that may not necessarily be, operated on. one study found that this amounts to $150 million in preventable healthcare costs. And so here comes the idea of active surveillance. How do we safely watch these tumors over time and waiting for the right time to intervene? Well, we know that the ideal candidate for active surveillance are small tumors, especially those that are less than 2 centimeters in size, those that grow less than half a centimeter a year, and those that are non-infiltrative. And what that means is that tumors that are well confined by a capsule, there's a clear distinction from where the tumor is and where the kidney is, rather than it growing into the kidney. And then if you've had this information available, if you've had a biopsy of the tumor, we can distinguish the different types of kidney cancer. Some kidney cancers are more aggressive, whereas other tumors are more indolent or slow growing. We also include the patient's factors. In the elderly, in the population with short life expectancy, or because they have a lot of comorbidities, the risk of treating the surgery may not outweigh the benefit of treating them of their potential cancer, as we're putting these patients at risk of surgery and or intervention. In addition, there are non-clinical patient factors, such as, is a patient reliable to come back, so that we can repeat imaging and to determine if the tumor has grown over time. Also, does the patient have resources? Can they afford transportation to come every 6 months so that we can repeat the imaging and assure that the tumor has not progressed? We also consider patient's preference. So by the time they see me, I might be a second opinion. They've already decided on whether they want to have surgery done or not, and what are their expectations. The referral pattern may also dictate the patient's decision. So if I'm seeing the patient and I'm diagnosing the patient with a kidney tumor for the first time, I present them all the options, including intervening, doing surgery, treating tumor, or watching it. The patient has the opportunity to absorb the information and weigh the pros and cons and decide for themselves. But if they're seeing me for a second opinion, which is often the case at Rush University Medical Center, they've already decided what they want. And most of the time, they are telling me, I want this taken out. It's causing me a lot of anxiety. So there's a lot of factors that are in play, including both the characteristics of the tumor as well as patient factors. And it's the intersection of all these different factors that help us decide if the patient is really fit for active surveillance of kidney tumors. Well, the evidence for active surveillance for the properly selected patients is actually quite convincing. And if you look at major centers such as Johns Hopkins or Fox Chase Cancer Center, amongst others, they found that when you're watching these tumors closely, most of these tumors actually grow very slowly at about 0.09 to 0.2 centimeters per year. And this is a safe rate. And also, surprisingly, some tumors don't grow at all, or they shrink over time. And it's not the fact that these tumors shrink over time, but it's just that when we're comparing imaging, there can be discrepancies. So what was thought to be maybe 4 centimeters initially might actually be 3.5 centimeters later on when we're observing these, which is reassuring because a lot of times patients are reassured that these tumors are not growing, and they know that doing nothing may be an option, especially if they may be at risk for surgery. The last point I want to make is that of the patients that are observed within 5 years, these large studies found that only 25% of patients progress. And by progression, I mean that these tumors grow fast, greater than 0.5 centimeter a year, or they get bigger than 4 centimeters. And we understand that at 4 centimeters or larger, this might increase the potential of the tumor being a cancer and the potential of it spreading outside of the kidney. Well, most importantly, patients will ask, what's the chance of this small renal mass spreading outside the kidney if this was kidney cancer? And one study in 2012 looked at 880 patients that they followed for 40 months, so almost 4 years. And they found that tumors that are small and are being observed very closely, 2% of the time it can spread outside the kidney. So not zero, but it is extraordinarily low, and which may be very reassuring for the patient. Also, an important question that is posed to me in clinic from patients is, if we watch these tumors, what is the chance of me dying from this cancer, of it spreading and potentially harming my life? And large centers found that if we were to watch these tumors closely, again, in the appropriately selected patients, the chances of you dying from this cancer at 5 years, it's pretty darn low. So 98.9% to 100% of patients who are being watched with these small renal masses are alive at 5 years. Now, I also want to present the downside of active surveillance. We mentioned before that, yes, cancer can spread, it's low, but it's not 0%. It's about 2% based on some studies. And are you really ready to take that risk? And this data here shows that what the potential of kidney cancer spreading to different parts of your body. And worst case scenario, in bad places, if it does spread, it might mean a survival of shorter than 2 years. And this is definitely something to consider and to talk about with your urologist. There's also a psychological distress with active surveillance, especially in contemporary times where we have access on our phone. We're able to look at results from the study, and knowing the information and understanding that, hey, this could be a cancer, might cause a lot of anxiety and or depression for the patients. And the studies that I quoted earlier found that about half the time, patients that end up choosing surgery to get their kidney tumors removed, about 50% of the time were not because the kidneys progressed, not because they gotten bigger or growing faster, but the fact that patients were just anxious and they would prefer just to get it treated and not think about it ever again. Now, this is also something to consider too, is that kidney cancer typically is a cancer in the elderly population. So the average age of when kidney cancer is diagnosed is about 64 years old. Now, if you were to be on this active surveillance protocol for the next 5 years, that would mean you would be 70 years old. And what if something changes? What if you have more medical comorbidities? You might not be able to tolerate surgery in 5 years, whereas you might be better to tolerate it now. And that certainly is something to consider too, whether you want to have an intervention done at the time of your diagnosis. This is also an exciting point for me as a surgeon, and it's something that I want to translate to the patient and caretakers, is that over time we've evolved the surgical techniques and the surgical technology that we use to treat kidney tumors. In the past, you might make a big open incision, remove the entire kidney, the patient's in the hospital for several days, maybe up to a week. And there's a lot of complications related to those big surgeries. Well, nowadays, we can take out small kidney masses from the kidney and spare 99% of the kidney function. And all this can be done through a 3-centimeter incision. And sometimes, if indicated, patients can go home the same day. So with these new techniques and technology, we've really lowered the risk of surgery. So which then kind of weighs towards surgical intervention rather than active surveillance as a preferable option for patients. And then the last point I want to make is that as perfect as we try to be as physicians, as perfect as a patient tries to be to follow up, they can fall through the cracks, and there can be many reasons for that. So if a physician retires or relocates, if your clinic cancels, if the patient's non-compliant, or if a big pandemic happens, that can throw a wrench in follow-up, and certainly patients can get lost to follow-up. And that's something that we always want to avoid. So I want to wrap up with with putting these points out there. So what if you have been diagnosed with a small renal mass lately? Well, I think if you hopefully sitting through this talk, you have the opportunity to understand more about your risks of cancer, of it potentially being cancer, and that watching it may be a safe option if you qualify. So ask your urologist, ask your oncologist if, how likely is your tumor a cancer, and what is the risk of it potentially spreading and potentially being a threat in your life. Also ask about your options. Today we talked about active surveillance, but there's also surgery, which urologists do. There's also what we call ablative therapies, where you freeze or melt the tumor. And there's also biopsy to determine what kind of tumor it is and what kind of cancer it is, which may help you decide on watching it or intervening. And then lastly, ask for a second opinion. Get a bunch of opinions, and if the opinions agree, then it certainly makes it more reassuring that you are choosing the right decision for yourself. So on that note, thank you for tuning in, and thank you for the opportunity for me to discuss active surveillance of small renal masses with you. And it's been a pleasure, and please reach out if you have any questions.
Hello, everybody. My name is Vourganti. I'm a urologist that focuses on the treatment of urinary tract cancers. I'd like to thank the Judy Nicholson Kidney Cancer Foundation for the opportunity to reach out to you in this meeting, which is a celebration of hope. And I've been asked to speak about robotic surgical approaches to renal masses. We've certainly come a long way, and it's not uncommon that people ask me about this, because the role of these new tools that we have, which I'm sure you've heard of, has grown over the years, and it's nice to get an opportunity to talk to you guys about this. So it's not uncommon that I'm asked if we're going to be doing robotic surgery. It's like, are you going to be doing the surgery? And I assure you, we haven't reached the point where an actual robot is doing the surgery. What the robotic system we're going to get into is a tool that surgeons have that they use in the operating room. Now, it's not uncommon for me, when I'm meeting with a patient, to talk to them about their cancer, is to show them sort of a schematic, or maybe I'll draw it on a piece of paper, or I'll show them where the tumor is, and we'll talk about maybe removing the tumor. On occasion, if it's really extensive, we talk about taking out the whole kidney. And most of the time, people focus on this. And one of the issues where the advantages of having new tools is it's never just this simple, because the kidney is surrounded. So you'll often see a picture like this, where you're just thinking of the little lump on your kidney that needs to get out. Sometimes you'll see a more comprehensive picture like this, where you see the kidneys and see them wrapped up, but really what they're hiding is all the good stuff that's on top of it and in the way. And that is that's really reflected on here, because here's the kidneys, and they're sort of like behind everything. They're behind all of the contents of the belly, right? And so they're hiding behind the colon and the bowel, and they're often hiding this. This is a very generous picture, but often the liver is sort of halfway hiding one side of the kidney. The spleen is on the other side. So there's so many things in the way. And it's not uncommon that, particularly in the beginning, that we used standard surgical techniques to get down to it. Here's a picture that I trained at the National Cancer Institute, where we tackled the most complex kidneys. And we wrote a nice paper, it's now over a decade old, about the surgical management of large renal tumors. And I spent some time putting together a figure where we talked about some of the very large incisions that are used for complex large renal tumors. And as you can see, you might make an incision And really the idea is we have to make room to get all of those other organs out of the way, because removing the tumor or removing the kidney is only feasible when you protect all of the things around it. So over time, what's been able to happen is we've developed this thing, and this is over 20 years old now, but essentially tiny little holes have been are able to be made, and most people will call it keyhole surgery or laparoscopic surgery is how it started. But basically, our ability to control the instruments where the patient's laying, and here's the surgeon operating in the room and controlling remotely these devices. So here's how an operating room is often set up. The surgeon's sitting a little bit away. The anesthesiologist is watching the patient. You have an assistant tending to the robot, and then you have a technician making sure that we have all the equipment we need, and everything's projected on monitors and so forth. And so, as you're likely aware, what this allows us, up until even very recently, is to make tiny little incisions and put these instruments through the abdominal wall. And then from there, we're able to use gas to move all of those very vital structures like the colon and the liver and the bowel and protect it so that we can get to the kidney. One of the things I want to talk about today is our ability as surgeons to take advantage of advancement in tools. So, when things started, we had like a more clunky instrument. And I don't know if this is very clear here, but this was in 1999, and then here in 2006 it got a little bit better, but really it was very similar right up until a couple years ago. We were able to develop a robot called the single port robot, right? And what this allows is all of these instruments to come through a single incision, right? And so that's a neat trick, because now what we're talking about is instead of making all of these many holes, we're even able to do it with much smaller holes. So it's not always appropriate, but in a well-selected case, what this allows us is new approaches, and maybe not being able to avoid the abdomen altogether. Here's an example where instead of going through the belly, we went right through the back, made a space. And one of the difficulties of this with our standard instruments, it's not impossible, but one of the difficulties is that there's not a lot of room back there unless you make a big incision. But with these new tools, where we're able to get all of these instruments together through a tiny little hole and control them all through our standard control system, is that we can get all of these things in there. And here's an example from our ORs, is where we're able to get in there and you're able to avoid the bowel, and you're able to avoid all the major structures and the liver and the spleen, and you can get right to the tumor. And here's a patient where we're able to just remove this tumor and make just a tiny little incision. This particular patient was able to go home the same day, although often we keep them for a single day. And that's very much better than the old days when we made these big incisions where people went home sometimes 3 or 4 days later. Sometimes the rib had to be taken. It was very painful. Now, whether or not these new approaches to kind of sneak behind the kidney and avoid all of these things are going to be very tailored, not only to the size of the tumor. So the bigger the tumor, this is a sort of a map that Dr. Chow, who is one of my partners, who is also giving a talk today at this meeting, put together, where we talked about when it's appropriate. And so in the bigger tumors, we're not able to use sometimes you have to use more instruments and use the more standard things. Sometimes we still have to make the full incision and open up the patient. But you're going to talk to your surgeon about when that is. And often we're really trying to push the envelope to make it, to keep the procedure safe and safe for the patient and be the right operation. Here's another thing, no one kidney tumor is the same. And so depending on where the tumor is and its size and the angles and whatnot, your surgeon's going to take a look at this and say, is it feasible to do this in a less invasive way? So one of the things that we're able to do now is remove your kidney and remove part of the kidney, and sometimes the patient's able to go home the same day. This was unheard of in the open surgery days. Certainly less pain. People are getting back on their feet, more quickly. Almost everyone goes home within the first day or two after surgery, and they're feeling a lot better. They look a lot better. So you're able to get back to your routine much more quickly. So I'd like to thank everybody for the opportunity to overview some of the advancements that we've had in our surgical tools. It's been exciting to see over the last 20 years how much the robot has advanced and changed. And it's been really nice to be able to bring that to the patients. And what we've definitely seen is a delivery on the promise of robotic surgery. We've seen less pain, patients leaving the hospital and the day after surgery, sometimes the day of surgery, which was unheard of in the days of open surgery where we have to make that big incision. Now, your doctors aren't always going to be able to offer that, and you're going to want to go to a team that has skills with not only the robotic approaches but the traditional approaches as well. But our goal is to get you back on your feet and to the next phase of your cancer story as quickly as possible. And I certainly think that robotics is currently and will continue to be a big part of that. I'll be available and looking forward to your questions during the panel discussions. And I want to thank the organizers and all my colleagues for the opportunity to speak today. Thanks.
Well, thank you all for being here today. My name is Alan Blank. I'm one of the orthopedic oncologists here at Rush in the Cancer Center. And again, I'm just privileged to be here to talk with everybody here today. Okay, so we're going to be talking today about updates on the surgical treatment of metastatic bone disease in renal cell carcinoma. And again, I'm Alan Blank. So, I'm an orthopedic oncologist, and to many people, it's a little bit of an unfamiliar entity of what it is exactly I do as an orthopedic oncologist. And it really is a hodgepodge of everything having to do with any lumps, bumps, tumors, or musculoskeletal growths. We deal with a lot of benign soft tissue and bone tumors, such as the various things that we have listed here: lipomas, myxomas, schwannomas. There's dozens of these things. Here's just one example. This is a benign soft tissue growth in the posterior aspect of the hip in a patient from a few weeks ago that ended up being a myxoma, which is a benign soft tissue growth. And we take it out, and that's what it looks like there, but they certainly can cause symptoms. We also deal with a number of malignant entities, such as soft tissue tumors and bone tumors. Soft tissue sarcomas are very common, and that is one of the main things that I treat. Here's a MRI of a soft tissue sarcoma in the thigh. You can see that circular growth there. That's something that we treat with surgery and radiation to take out. We also treat a number of bone tumors, both chondrosarcoma, which is overgrowths of cartilage like you see here, and the humerus in the shoulder, which we treat with a removal and a reconstruction like this. And also osteosarcomas, which is basically a malignancy of the bone itself. You can see this in the middle of a tibia in a young patient that we also treat with a removal. This also gets some chemotherapy and then a nice reconstruction to make the bone strong again. Additionally, we treat Ewing sarcoma, which is another type of bone sarcoma. And then finally, metastatic bone disease, which is actually one of the most common things that I treat. So metastatic bone disease is basically any sort of a cancer that happens to then find its way metastasizing to the bone. It can be from any number of organs. Additionally, we kind of lump in myeloma and lymphomas in the category of metastatic bone disease from a surgical perspective. So why is metastatic bone disease important? Well, from the epidemiology of it, it's really critical to understand that it is ever prevalent. There's over 250,000 cases of metastatic bone disease in the United States. It's a huge cost to patients and hospitals, and there's many benefits to treating this faster rather than slower with surgery. Here you can see a table of some numbers of the most common types of metastatic bone disease in the US, and just below lung there actually would be renal cell, but it is one of the more common entities that metastasizes to bone. So I'm not going to belabor the points of this slide, which is just that the mechanism of bone destruction and deposition in metastatic bone disease is very complex. It's something that we study at a basic science level here at Rush, and we're involved in a number of research grants and projects investigating this. But it is an ever-growing understanding of the various pathways by which metastatic cancers in the bone can lead to destruction of bone. Because interestingly, some cancers that spread to bone actually will grow bone. Breast cancer, prostate cancer, for instance, are very, very common to actually grow new bone, whereas very many other cancers, including renal cell, is more common to destroy the bone, as we'll see in a few cases. But again, this diagram here really is just to emphasize the fact that there are a whole number of pathways involved in this process. It's a very complex sequence of events. So what is it you say you do? You know, I consider myself as an orthopedic oncologist to be a structural engineer of bone in the setting of metastatic bone disease. So when these cancer cells spread from their primary site and get into the bone, they wreak havoc kind of like termites on wood. Right, so here you can see a picture of some termite-infested wood, and on the left there, you can see the 2x4 that's got holes in it, and on the right, you can see the new 2x4 that's been put in as a structural support system. That's very similar to what I do when it comes to metastatic bone disease. So this is an example of a patient with metastatic bone disease in the femur, and you can see all of these darker spots within the bone. These are areas that are, as we say, lytic or destruction of bone. And it's causing the bone to be very, very weak. If we don't do something about this, the bone will break. And we know if the bone breaks, it is just an unfortunate situation for the patient. So what do? We treat it with an intramedullary fixation construct. That just means some sort of metal implant. This is one that goes right inside the middle of the bone, and it holds it strong and prevents the bone from breaking. So what else do we do as structural engineers? Well, we replace the tires or wheels on a car, if you will. So sometimes these areas that have destruction in the bone aren't in the middle of the bone. Sometimes they're closer to one of the joints, like the hip or the knee or the shoulder most commonly. And when it is very close to that joint, it can cause a lot of pain, destruction, and even symptoms consistent with just a severe arthrosis or arthritis. This is an example of a patient with metastatic bone disease in the pelvis. And you can see here that there is a whole basically portion of the acetabulum or the socket part of the hip that is basically missing. That should be white bone there, and it's all missing. So what do? We basically have to find a way to reconstruct the functional unit of the hip joint, which is a ball and socket joint. And here you can see an MRI also demonstrating the extensive appearance of that lesion right above the hip joint. And we treat that with a joint replacement. And it's a very, very common way that we treat these issues and make patients function better, feel better, and really improve quality of life. So this is not working on an island, though, as an orthopedic oncologist. I have to give a lot of credit to everyone who's a part of the multidisciplinary team that involves medical oncology, who really drives the ship, radiation oncology, pathology, radiology, interventional radiology. There I am as the orthopedic oncologist, PAs, APNs, RNs, social workers, and family. And family doesn't get enough credit. They really should get more, because oftentimes the decision of what is the next and best thing to do is best decided with the assistance of the family. So who's a candidate for surgery when it comes to metastatic bone disease in the setting of renal cell carcinoma? In orthopedic oncology, we actually have a tried and true system that's been around, believe it or not, since 1989. This article came out, basically risk stratifying bones that are at risk for fracture with metastatic bone disease based on a couple of different factors. The first factor is where it is and which bone it's in, whether it's the upper limb, lower limb, or peritrochanteric, that just means around the hip, how severe the pain is, what the appearance of the lesion is, whether it is growing some new bone, destroying bone, or some mixed process, and the size of the lesion. So each of these categories gets a score, and at the end of the day, we're able to calculate based on that score what the percentage chance there is of that bone breaking. We generally say that scores above this number of 8 are high enough risk for fracture that we consider moving forward with prophylactic surgery to fix the bone before it breaks. So why do we fix bones before they break? Actually, there's some pretty good older evidence from 20, 25 years ago showing patients who have bones fixed before they break have improved ambulatory status, decreased pain, less fixation failure. That basically means the implants that we put in and the devices that we use to fix these have less of a chance of failing, and decreased mortality. Patients seem to live longer in those cases where we actually fix the bone before it broke. This is just an example of an X-ray of a patient with another intramedullary device that you can see it's a rod down the middle of the femur with kind of 2 screws that go up into the hip. So what else do we know? About 10 years ago or so, some new studies came out showing, again, lower rates of immediate post-op death. So patients do better before they break if we can fix the bone. These patients live longer. They require fewer transfusions of blood in the hospital. They function better, and they stay in the hospital much shorter periods of time. So again, more benefits were seen with treating these patients who have impending fractures, as we say, before they break than after they break. Some more modern studies have looked at some other factors and found things like higher discharge rates to home rather than rehab. Here's a study that we did a few years ago also showing lower cost and shorter admissions when we treat these patients with prophylactic surgery. And here you can see just another example of someone that we treated prophylactically. You can see here on this side of the bone, all of that cortex or wall of the bone seems to be missing from the destructive process. So this implant really goes from one side of the femur to the other, protecting the whole bone. What else have we found? We looked at patient-reported outcomes, which are really a new entity in the surgical perspective literature, but also in medical oncology. These patient-reported outcomes score, I think they're going to be the new standard very shortly, and it's basically the how your outcomes are by a patient perspective. So patients fill out these forms to tell us exactly how they're feeling, pain-wise, function-wise, and we're able to actually compare those numbers to historical averages and general population numbers. So we found in patients treated for metastatic bone disease that the pre and post surgical PROMIS scores for 43 metastatic bone disease patients showed really good outcomes. We had improvement in pain, improvement in function, and we've really expanded this to now have a multi-center study that we're part of. I think it's now 15 institutions that's collecting longer term data, but so far so good. So that study and those previous studies were mostly talking about, fixing bones before they break, those big rods and femurs and humeruses and tibias and things. What about joint replacements like we touched on earlier? Well, there's some good evidence showing that joint replacements in the setting of metastatic bone disease is also very helpful. This was a large study which recently was published showing over 300 cases of joint surgeries for metastatic bone disease, very low rate of implant failure, 3% to 2 years. And overall pretty good survival at 1 and 2 years as well. So just showing that these cases where joints are destroyed from the metastatic process, it makes sense to move forward with the joint replacement. We looked at a lot of our data from some of these larger reconstructions we've done in the setting of metastatic bone disease and found some similar findings. We found a pretty low revision rate at 5 years, very low dislocation rate as well. You can see there, this was published in one of the orthopedic journals fairly recently. And similarly for the knee, we found overall pretty good rates when we do reconstruction of the knee. Low revision rate of 5 years, 36% revision rate at 10 years, which is kind of as we say, the industry standard and right on par with where it should be. We published this as well. So again, we really do believe that if the hip, the knee, the shoulder are intimately involved with the metastatic bone disease process, replacements can really improve function with relatively low risk for morbidity or complication. Sometimes the decision, though, is a little bit challenging. Having to decide whether we do this fixation technique where we put the metal rods in, or whether we replace with something like this. And it is a challenge because we know that there is a risk of these implants breaking with time. If the metastatic process can't be controlled or progresses, certainly that's a lot of wear that goes on that metal implant. And I always describe like a paper clip bending so many times, eventually that paper clip will break, and that's what will happen if the bone doesn't get stronger. And that's what happened in this image in the left, actually. This is a metal rod. You can see the top part of the metal rod right here should actually be right in line with this bottom part. You can see it's off by a little bit. It's kind of translated like this. And that's because the metal rod broke. And when this happens, it's a difficult situation, and we end up having to remove everything and do a joint replacement at that point, which is still a good outcome and a good alternative for these patients. But we were curious to see if we looked back on our outcomes with these and see if we could learn anything. And we found about 115 patients in both categories. And we found that the rate of failure with trying to fix these was a little bit higher than the rate of failure with trying to replace them with a joint replacement. On the flip side, the replacement had a little bit longer hospital stays, OR time, and blood loss. So, it's kind of, as we say, pick which way you want to go based on the potential pitfalls you may face. But this was certainly a helpful article. And again, this was published fairly recently. So I want to just skip topics really quickly here to talk about, is there ever a role for negative margin resection with metastasis? So all the surgeries that we've been talking about so far for a metastatic renal cell, they have to do with surgeries that are really meant for improving function, improving pain, and improving the stability of the bone. But their primary goal is not to remove the cancer that's there. And oftentimes we have the belief that, if the metastatic process is so extensive, it's unclear if removing that one site of disease really makes a big difference in the scheme of things with all the other sites that are going on. And this is demonstrated here by this diagram showing the different ways that we do surgery in the setting of cancer, right? The first little dotted line is an intralesional excision. That's where you leave some of the tumor behind. The middle one is marginal, where you kind of remove the tumor right on the border of it. And the other one is wide. So this is removing all the tumor, and there's no more tumor from that site of disease. And, it is a hot topic in the surgical oncology and orthopedic oncology conferences, if this makes sense ever in the setting of metastatic bone disease. And believe it or not, in the one setting that we often come back to talking about when it may make sense is in renal cell carcinoma. And a lot of that is based off this article and a couple others. Looked at over 1,700 patients with renal cell carcinoma, 300 with metastatic bone disease. 7% of these had solitary sites of disease in the bone. And it seemed that solitary bone metastasized patients had improved survival over the visceral metastasis, so the other sites of metastasis than bone. And radical resection or a negative margin resection of these isolated metastatic sites was associated with an improved survival. So, in short, in a select group of patients with metastatic renal cell carcinoma, it made sense to go ahead and remove that one site of cancer in the bone, and it improved patient survival. So that's something that we do here, not infrequently, when the situation is correct. And I wanted to show this case example as a good case in point. So this is a 60-year-old male I saw a number of years ago now with renal cell carcinoma and a single metastatic site. The primary lesion was actually removed from his kidney 5 years ago, and now he has severe hip pain. You can see here on the x-ray, there is a big, looks like almost a shark bite out of the proximal femur here from the disease. And that is certainly at risk for breaking, and something needs to be done about it. Because this is an isolated site of disease, he's a young patient at 60, and the primary site of disease was removed years ago. I thought he was a very good candidate for a negative margin or a complete resection of this tumor. And then we could treat it with a proximal femur replacement. So the first step, and perhaps the most critical in these cases, is to have interventional radiology cut off the blood supply to these tumors because they are very, very vascular. Here you can see a picture of the angiogram from interventional radiology when they actually cut off this is the before. You can see there's a whole web of these black lines here. That's all the blood supply there. This is them putting a little device in right here with that cuts off the blood supply. And now you can see there's no little black lines where the tumor is. So this is what they do to help us with the surgery to decrease the blood loss during the surgery. And then we replace it with what's called a proximal femur replacement. So you can see everything that's white here is actually a metal implant. And this patient did very, very well. In fact, so well that, and he did very well on his medical treatment as well. He came back to see me 2 years later. So 2 years after the primary site was in the hip was removed, and he started having some shoulder pain. So we get some x-rays, excuse me, and you can see the same process is happening on the proximal humerus here, right? There's almost a shark bite of missing bone in the proximal humerus. And again, this is 2 years after the first site was operated on. So now we're 7 years removed from the primary renal cell carcinoma in the kidney that was removed. 7 years, which is unbelievable. So he was having such bad function and pain that we did a similar procedure for the shoulder, and this is called a proximal humerus replacement. You can see there's the little embolization device that the interventional radiologist used before the surgery, which was very helpful. And he did terrific from this. This is actually a video of him about 3 months after the surgery, raising his arm up very, very well, all on his own, with minimal to no pain. This is very impressive that he's able to do this just 3 months out from surgery. And that's really a credit to the implants that we use and the systemic treatments that he was getting to help control his disease. So again, it's really worthwhile to consider sometimes removing the disease that's in the bone in the right situation. But some of these procedures seem extensive, right? Many solutions seem quite invasive. And the question always comes up, isn't minimally invasive surgery making its way into orthopedic oncology yet? All these other specialties and surgery are doing surgeries with lasers and through small holes. There's got to be some way that we can do this as well. And the answer is yes, not when it comes to actually removing the tumor, but when it comes to stabilization. So we've been doing a fair amount of percutaneous treatment of metastatic bone disease in the pelvis. And we're one of the first centers in the country to do it, the first in Chicago. And what we're doing is we're treating these lesions in the pelvis with a combination of large metal screws and bone cement to stabilize areas in the pelvis that are very weak and causing pain. You can see this is an example of a cancer in the pelvis here. There's a big hole in the bone, and percutaneously through 3 small poke holes like this, we're able to access the lesion. Basically, we put these metal screws across the pelvis in specific trajectories to reconstruct the anatomy of the pelvis. And then through those screws, there's actually holes in the screws. We can insert a special bone cement to fill in the defect, fill in that void. And we've found, we're soon to publish a series of about 50 cases between 3 institutions, significant improvement in pain, function, ambulation, very few complications. So we've had a very successful experience so far doing it. You may ask, why do you have to add the cement to this? Well, it's a similar construct to how highways and bridges are built. Screws alone are pretty strong. Cement alone is pretty strong. If you combine the two in this fashion, it really makes a construct that is incredibly stable and lasts with great durability. So that's the rebar effect, is what we say. So in summary, metastatic bone disease affects a large number of patients, unfortunately. And I, as the orthopedic oncologist, am really a structural engineer here. There's many interventions possible to improve pain, decrease function, lower acute morbidity, mortality, and decrease cost healthcare utilization. I think we do a very good job here at Rush with a multidisciplinary approach to treat our patients with this problem. And again, please talk with us if you have any questions, comments, or concerns. We're always happy to talk. So thank you very much. This is actually a picture a year old now. I got to get a new one because this past summer we actually had a new Swim Across America, which is a cancer research fundraiser we have as part of Rush. That's a very successful fundraiser. If anyone's ever interested in swimming a little bit in the lake for a great cause, it's terrific, and it's every summer. So thank you very much.
There have been a couple of questions about people who are newly diagnosed or in different cancer stages. And I just wanted to make sure that if anybody had questions about the content of the speakers' presentations, and then if there was any specific questions, we're somewhat limited in answering like medical questions, but we can kind of give general overviews. And I think that having done these before, I think we all have that there can be a lot of meaningful information passed on.
Thanks, Dr. Vourganti. I'm sorry, I'm just seeing the main comments section now. I was in the private chat thing. I do see. I see one question: is it safe to do when patients have poor wound healing? And would you mind elaborating on which presentation you're referring to, if you're still on? Linda believes it was Dr. Chow's presentation.
I can speak to that a little bit. I think Dr. Chow's presentation was overviewing the role of active surveillance of a renal mass, and he was talking about the small renal masses. If the question was in someone with poor wound healing, is active surveillance a reasonable strategy? Actually, it would be the best strategy. One of the best things about active surveillance is it's taking into account the risk of what we find. We're not treating everything the same, and we're personalizing the decision making. And there are definitely times that you're going to treat the same exact cancer differently depending on the patient who's showing up. And so, in general, if you have other medical problems or comorbidity, we talk about observation as an option for these things because you're balancing risks. So, answer to your question, for many people, as long as you're being followed, if you're felt to be a low risk, and usually these are based on size and how the tumor looks, you can be followed with active surveillance. And then if you have poor wound healing, that would be adding to the weight of observing over intervening. However, having said that, it doesn't mean that intervening is wrong, because we have ways to address wound healing if after you've made all of the decisions and you put it together, a decision is made to go forward. In case you have a health condition that makes healing impaired, we can get around that. Usually it's nutrition and just watching the wound, and sometimes we get our plastic surgery colleagues involved to make sure that the wounds will heal correctly. I hope that answers the question.
And I'll add a little bit from my perspective too, just because I, as you saw in the presentation, I help with surgeries for metastatic lesions in these cases, and exactly like Dr. Vourganti said, we have a lot of crafty ways to help minimize the chance of infection, whether it's doing less invasive techniques, involving plastic surgery colleagues along the way, really working with the medical oncology team to tailor, exactly how far before treatment to stop, before surgery to stop treatment, and when to start it up again after. So, the team-based approach is really critical for minimizing the chance of infections and wound healing issues.
I saw a clarification of the question, which makes a little bit more sense. The question is, can you do tumor removal in someone with poor wound healing? And it does come up, and like I mentioned, you have to, if the tumor needs to be removed and it's in the best interest of the patient, then we do it, and we manage these complex wounds. One of the nice things about our institution is, we have very multidisciplinary surgeons. We partner with radiation oncologists and medical oncologists who you meet during this symposium, and we work together. So there are situations where patients are on systemic therapy, whether they're on the targeted agents or immunotherapy or whatnot, and some of those agents are shown to impair wound healing. And so we work with the medical oncologist to make sure that the patient gets a break around the time of surgery, and has time. And the other thing that we notice is we're able to get our incisions smaller and smaller as time goes on, particularly with robotics. Instead of one really large incision, it might be multiple small incisions, which is something that the body can handle a little bit better. And in fact, I think we talked about I mentioned in my presentation that that we have the single port system that allows us, even in select cases, to keep to really reduce the number of wounds. And many people, particularly for localized kidney cancer, are going home the next day, and wound problems tend to be very, very minimal. I see one more question regarding being in the post-treatment phase, which can be a tough one because it doesn't really end for a very, very long time, right? And so there's a bit of a catharsis. There's the threat of the cancer, particularly in the localized state, when we remove it all, and you're wondering, is it going to come back? And so we have a question in the chat of someone with a very, very large tumor. That was the most common kind. Dr. Park had gone through all the different, the main different kinds of kidney cancer. And there's a question like, I don't really know how common it is. And so, predicting the future is something that we're asked a lot to do. We do know a little bit about it. And one of the reasons why we watch is that even when you remove all of the cancer, it can come back. It's much less common to come back when the tumor is smaller. It's less likely to come back when the tumor is less aggressive. And there are risk calculators and statistical models that you can kind of grind in your age and your sex and the size of the tumor and the type of tumor and other patient factors like tobacco use and whether you could feel it when we found it, whether it was symptomatic at presentation kind of thing. I would say for a large tumor, such as what was mentioned, it could come back up to about a third of the time. The longer you go out, the longer time goes out where it doesn't come back, those odds get rosier and rosier, meaning it's less likely to come back. They call that conditional recurrence-free survival, which is a complex way of saying the longer you go out and it's not back, the less likely it's to come back. But one of the challenges is there's never enough time where that number goes to zero. And so you're going to get into a sort of a personalized decision-making plan with your doctor. Most of the surveillance strategies after removal of the kidney cancer go out as far as a decade, where at first the checks are much more frequent every few months. And then as time goes on, it might go to every 6 months, every year. In the second half of the decade, you might even go every other year, right? And the reason is that cancer can come back. Cancer can come back late, and this doesn't always mean that it's going to take over. It just means that more treatment will be required. And in general, it is very multidisciplinary. You're going to need the help of medical oncology, sometimes radiation oncology, and occasionally second surgery is done. But and you have to look all over the body. You have to look in the lungs. You have to look in the abdomen, and whatnot. So I hope that helps address the question for Rachel. Other than that, I'm scanning the chat. I'm not seeing any burning questions. Whether there's a question about the content of our presentation or anything else that we can help you about, we're happy to address.
I guess I'll ask a question. Dr. Park, hi, nice to see you. Anything new and exciting in the world of pathology and cytopathology that is on the horizon that we should be looking out for?
Well, there's always new developments happening, especially regarding the molecular world when it comes to pathology. I think right now we're still in the process of renaming things, recategorizing things, and the newest WHO book for GU pathology is actually in the process of being finished. So, you know, there's definitely more on the horizon and more changes happening all the time. I think pathology is one of those worlds where we are always learning something new.
Great. I know every time I go down there and talk to you guys, I learn something new. So I agree with you.
One thing I can tell you that's coming in off the street is the genetics portion, where people will come in without a diagnosis. You know, I trained at the NIH where they discovered a lot of these kidney cancer genes, and they helped with sort of the molecular characterization and the cancer genome atlas. And it used to be that you had to go to like a major research lab to figure out about your genes. And I've had patients, they were working at a firm in downtown Chicago, and instead of getting massages, they all got their genomes sequenced. And so they came in like a ton of bricks because they found, a germline mutation, which would have been, even 5 or 10 years ago, you would have had to have been collaborating with the leading researchers in Boston or New York or abroad to find out. And then they just found out because your genome is a lot more at your fingertips now. And we don't, there's a new state where people will come in with new risks. Like it used to be maybe, oh, well, it kind of runs in my family, I'm worried about it, but we couldn't put our finger on it. And we're still there, but we're finding more and more people that have absolutely nothing wrong, but we know that they have a cancer susceptibility gene, and that can be its own thing. So one nice thing that we have as a resource at our institution is we have excellent genetic counseling. And I do find that people will be, the cart has gotten before the horse in this, where companies will offer it to you, you can mail it in, you can do it on an app, and then you get all this information and you're alone. And the role of genetic counselors here cannot be overstated. So we'll often, I'll even, making the decision to check your genes is a big question. Do I even want to know? Most of the time the answer is yes, but you want to answer it in control, right? And so having genetic counseling can be very helpful because it can often open up a little Pandora's box. I don't know if you guys have seen this, but I'm definitely seeing people where you'll Google it and you'll be like, wow, this person just found this out, and there's maybe only a few very high-end reports about it, and we're having to sift through this in really the front lines, which is really interesting. So
it's funny you mentioned that. I actually see at least a couple of times a year people who get, some corporations now require extensive medical testing prior to onboarding, and they offer even full body MRIs. So I will have people come in not infrequently with full body MRIs that are otherwise very healthy, and a plethora of just incidental findings. So same idea, just kind of on a macro level rather than a micro level. But you're right, information is wonderful, but information kind of in a vacuum is challenging to interpret.
It's a highly relevant topic for kidney cancer, because after the advent of CT scanners, we found so many tumors that patients would have lived and died with, not of, and we got very much to business. And this is why Dr. Chow's talk, on active surveillance is quite relevant, because actually there's a concept that we know as interventionalists, as cancer doctors, called the treatment disconnect. So in the 90s and the 2000s and the 2010s, we got very busy operating on tiny little renal masses because we discovered them. And actually the death rate from kidney cancer is not plummeting. So wherein we have to win is we have to win by preventing the advanced kidney cancer, but not over treating the small incidental ones. And so that is a journey. That is absolutely a complex decision-making process. And thankfully, we're working on, genetic signatures and care pathways that we can reassure patients so that they don't overdo it. They don't threaten their kidney health and their to cure something that doesn't need to be cured, but you also don't want to ignore something that's a threat. I believe that we're winding down. If there are no questions, I believe that we're going to get a short break, and then the proceedings are going to restart at about 9:50.
Great. Thank you very much for having us, everybody.
Thanks, everybody.
Thank you.
Thank you very much. Thank you, organization committee, to invite me to give the talk. My name is Dian Wang. I'm the MD, Ph.D. fellow of Astro. I'm a professor of radiation oncology, adjunct professor of urology at the Rush University Medical Center. Title for my talk today is Imaging-Guided Stereotactic Body Radiation Treatment, SBRT of renal cell primary cancer and its oligometastases. Learning objective of my talk is at the conclusion of this course, participants will be able to learn advances in radiation treatment technology for renal cell cancer and its oligometastases, current ablative treatment, SBRT, of the primary renal cell cancer and its oligometastases, and radiation-related research in renal cell cancer. I have no disclosure. Radiation treatment is based on the technology advancement, which makes the radiation treatment now is accurate, highly conformal, that played a significant roles in treating renal cell cancer and its oligometastases. I like to show those slides which reflect the history of radiation treatments. I showed those slides to ASCO back to 2014, which showed that in radiation oncology and starting approximately 1896 in the United States, and we started radiation treatment. At that time, it's pretty simple. The clinical bedside setup based on anatomy. Starting 1960s, we call it two-dimensional radiation treatment, also based on anatomy. In starting 90s, at that time, we call it three-dimensional conformal radiation. And typically, is intensity modulated radiation treatment called IMRT. We can focus on high dose radiation to treat the tumor volume and the shape and the normal tissue, to spare normal tissue from high dose radiation. The later, we identify tumor is moving targets. In some tumors, moving targets. So we starting to have what we call four-dimensional CT scan, gated radiation treatment, or imaging-guided radiation treatment, or adaptive treatment. When during the course of radiation, we notice the tumor is changing, we can adaptive radiation treatment. And in 2016, we're starting to have MI-based linear accelerator, which is advanced radiation treatment to focus on some of the tumor, which is difficultly verified imaged and CAT scan. I would like to give you a little bit of details about radiation advancement in imaging guidance, which is a big significant deal in guiding the radiation, high dose radiation to tumor that spare normal tissue from high dose radiation treatments. Now these days, number one imaging guided technology is CAT scan based, equipped with the treatment machine. and we can identify soft bone and soft tissue, and sometimes in combination with the placement of fiducial markers, which enhance in identification of the tumor and the normal tissue. We're also able to get using ultrasound to identify the tumor every day and before treatment. And I just mentioned that the MI linear machine available since 2016, which is can be utilized to imaging some of the soft tissue, the tumor, which is much better imaging compared with CAT scan, traditional CAT scan. We also noticed that some places using orthogonal images using KV and megavoltage X-rays enhancement with the fiducial marker placement. This is commonly utilized in majority of centers of radiation oncology. So this is the radiation treatment machine equivalent with the cone beam CT scan. So every day, this is a beautiful example of our these days in treating the prostate cancer. We are using the CT scan to look at the prostate, look at the fiducial marker, look at the bladder, look at the rectum. We give a high dose radiation to prostate, spare the radiation from high dose radiation from the normal tissue structure, rectum, and the bladder. This slide is showing that a majority of image-guided radiation oncology machines. So nowadays, when you visit radiation oncology department, you will see the 2 to 3 kinds of machines in the radiation oncology department utilized to treating the cancer. And this slide is showing that at these days, regardless where a tumor is, primary or metastasis, we are able to deliver much high dose radiation to tumor, spare just the normal tissue structure from high dose radiation treatments. And as I mentioned that over the years, we noticed that some of tumor is a motion change each day between the daily fractionation. And sometimes the change can be based on, because of anatomy change, the tumor size change and shape change during the course of radiation. We also notice that some of tumors we call interfractional, means during the radiation treatment, we need imaging tracking. If we don't have imaging tracking, we're gonna miss the targets. And this slide showing that representative example, when the tumor in the lungs or metastasis of lungs, the tumor can be changing the motion. When we see that, this is the renal cell cancer, and you will see that on the left lung, the tumor is moving and during the respiration, during the course of treatments. So for this patient who has metastasis, oligometastasis in lungs, we can perform the 4D CT scan in Department of Radiation Oncology, and then we can contouring the tumor. We'll give a little bit more margins based on the tracking, based on the motion. Then we will not miss the tumor during the course of treatments. This is the beautiful example here showing that sometimes when we had to put this fiducial marker, which is a sensor implanted to tumor, then we can keep track of the tumor motion. This is the top slide is for prostate cancer. And the second slide is using ultrasound and tracking the prostate, and then we give the treating. And the final, the slide 3 is using multiple camera and then monitor motion during the radiation delivery. And this will give us accurate clue how's the tumor motion, how we give a good margin and give a high dose radiation to spare the tumor, spare normal tissue structure from high dose radiation. In addition, I'd like to show you the concept of a dose fractionation. Radiation oncologists will tell you sometimes give you 40 gray and 50 gray, and that's not right. Most of the time they should give you the 50 gray, let's say 5 fractions or 10 fractions, that is a matter of radiation, effective radiation dose. So you will often hear that conventional dose fractionation is only 1.8 to 2 grays low dose per day, and typically 5 weeks to sometimes 9 weeks radiation to kill the cancer. And nowadays, you probably also hear that we call moderate hyperfractionation, means the radiation dose is more than 2 gray or twice-day radiation. On your right side, you will see SIS, stereotactic radiosurgery, or stereotactic body radiation treatment, SBRT, is a much higher dose per day per fraction, typically more than 5 gray per fraction, 1 to 5 fractions. The middle moderate hyperfractionation was and SIS SBRT together, in general, radiation efficacy is increased, means that we can killing the tumor better than conventional radiation, but we always with general concern about increase of acute and or late side effects. So that is, today we're going to focus on SBRT, the high dose radiation treatments and stereotactic body radiation treatments and the house imaging guidance. Stereotactic body radiation treatment, SBRT, is characterized by delivery of a high dose of ionizing radiation in few fractions. It is highly effective in achieving local control. And due to the high biologically effective dose administered, it seems to overcome the radio resistance of renal cell carcinoma. I will mention that later. And therefore, SBRT could constitute a treatment option for management of localized renal cell cancer in patients who are not surgically candidate. What's the rationale of stereotactic body radiation treatment on renal cell cancer? That's based on at least the 3 common reasons. The number 1 reason is the clinical observations. In general, renal cell cancer relatively slow growth compared with other type tumor like lung cancer. And a relatively slow growth indicative of not well responding to radiation treatments and conventional radiation treatments. And the second is with a lot of studies have shown that in history, we always say radio resistance is not well responding to conventional dose fractionation, the radiation dose and dose fractionation. And the second is radiobiological reasons. The renal cell cancer study has shown that alpha beta ratio for renal cell cancer is relatively low, is 2.6 to 6.9. In typical high growth tumor, there will be 10. That's the kind of a term of radiation oncology using for tumor biology. Then also recently the SBRT using the high dose, 48 gray in 3 fractions means that each, probably a 16 gray per fraction, means very high dose, can result in tumor size reduction quicker, and the cell metastasis is also minimal in xenograft models. The number 3 reasons is pretty hot topic. It's called synergistic immune enhancement, which is currently under investigation. Stereotactic body radiation treatment, the high dose per fraction can stimulate immune system. It's called peritumor immune or escapable effect. What is the escapable effect? Which means that is when we give radiation to one tumor, one metastasis, which you can have escapable immune effect to distance the tumor, which was not treated, but is responding and shrinking or disappeared. And the second thing is renal cell cancer, especially clear cell type, has high immunogenic features. I think that this topic will be given by our medical oncologists regarding efficacy of immunotherapy of renal cell cancer. And that's SBRT. That's the reason we're saying that SBRT and immunotherapy can have a synergistic effect. This slide is showing that multiple studies, clinical trials has been done about high-dose stereotactic body radiation treatment on renal cell cancer. I don't have time to talk about each of the clinical trials. And I would like to show you one representative study is a stereotactic body radiation of oligometastasis extended overall survival. This study was published in the Journal of Clinical Oncology in 2 years ago. But this not just the focus on the renal cell cancer, it's overall, including renal cell cancer. And they have 99 samples divided into 2 cohorts. One cohort is just a control without any stereotactic body radiation treatment. Another cohort is receiving stereotactic body radiation, high dose radiation treatments. You can see over the 3 years in follow-up showing that significant improvement in this overall survival on left side. You see the overall survival significantly improving, which when the patient was receiving called stereotactic body radiation treatments. And here they're using SABO and is ablative radiation treatments. Is a similar stereotactic body radiation. On the right side, you will see progression-free survival, disease-free survival, showing the significant improvements. So, what is the indication to treating the renal cell cancer? Number one is a primary renal cell cancer. We can using SBRT as an ablative alternative in those inoperable, means that a patient cannot have surgery, but patient have preserved renal cell function. For example, we typically using the GFR in more than 70. Typically, tumor should be less than 7 cm. And because if you're more than that, then the majority of kidney will receive radiation. So we're not able to preserve renal function. I think that those conditions and patient can have alternative option using SBRT to treating the primary cell renal cancer, which is not operable. And second, is recurrent renal cancer, especially after surgery. And once you have a surgery, and sometimes in the surgical bed and tumor come back, it's very difficult to have another surgery to remove the tumor. At this situation, stereotactic body radiation treatment can help as an alternative option. Number 3 is metastasis. Metastasis is divided into oligometastases. Oligometastasis means that probably 3 to 5 the tumor which can be ablated by SBRT treatments. And patient can have a diffuse metastasis. In those patients have diffuse metastasis, and lots of times just the symptomatic palliation, and we don't need SBRT for that, just regular radiation, just help with the pain. However, some of the diffuse metastasis has treated responding well to systemic treatment, typically like immunotherapy or targeted agents. And there's only 1 or 2 tumor progress, we call progression. And those patients will be benefited from high-dose radiation SBRT treatments. This is a typical slide. This is a representative slide. I'd like to show you 3 cases. In this case 1 is recurrent renal cell cancer, had a surgery, you can see the kidney on the left side was already removed in the history, and now has a tumor in the lymph nodes adjacent to previous tumor bed. And this patient will have a difficult resection, and we can give SBRT. You can see the beam angle, the beam is concentrated on the tumor. Less radiation spared, right kidney will be spared from high-dose radiation. And the left slides, axial slides, middle is coronal slice, and on the right side is sagittal view of high dose radiation concentrated on the tumor, the spell, the adjacent normal tissue structure, including kidney and the spinal cord. The second case is, and we can be showing that the perispinal metastasis. This patient have a tumor in renal cell cancer, and showing that perispinal metastasis, and we can give high dose radiation and treating this perispinal metastasis and spare adjacent structure like a kidney and the spinal cord from high dose radiation. And this, you can see that how accuracy of radiation deliver to the perispinal metastasis. A case 3 is oligometastasis progression in number structure area 4, fourth vertebral body. You can see that we only give radiation just to treat the area 4 tumor. This patient has a history of area 5 and stereotactic body radiation, and now we are treating area 4 vertebral body. And we'll give very high dose, 3 fraction and 27 grade total in 3 fractions to the area 4 vertebral body. Again, left is axial images, middle is the coronal images, and on the right is the sagittal images. And you can see the high dose concentrate on tumor, spare the adjacent structures. Only 1 vertebral body irradiated. So summary of my talk is imaging-guided stereotactic body radiation treatments, high dose in few fraction, capable to ablate renal cell cancer with a high local control. And number 1 is able to ablate inoperable primary renal cell cancer with preserved renal functions. Number 2, able to ablate recurrent or oligometastases, which improve the patient's survival. Number 3, able to ablate oligometastatic progression during or after systemic therapy. I just want to emphasize that, which I already explained before, meaning that those patients, even though have diffuse metastasis, but responding well to systemic treatment such as immunotherapy or targeted agent, and only 1 or 2 tumor progress. In this situation, we give SBRT high dose radiation can overcome the resistant clone, which is killing them and providing the outcome benefits, survival outcome benefits. Finally, there is an synergistic immune response for renal cell cancer with high immunogenic features. And for those patients, typically clear cell carcinoma, and those patients responding well to immunotherapy, if you have oligometastasis, oligoprogression, I think that those patients probably will benefit more from high dose radiation, stereotactic body radiation treatments. And I would like to thank the Rush University Medical Center GU Prostate Oncology Program, and also our Radiation Oncology Department and Department of Physics, who can help me to planning such difficult high dose radiation to treating the renal cell cancer and its oligometastasis. Thank you very much.
Hello, everybody. My name is Timothy M. Kuzel. I am the Samuel G. Taylor III Professor of Oncology at Rush University Medical Center. I'm the Chief of the Division of Hematology, Oncology, and Cell Therapy. And I also manage many patients with urologic tract tumors, including kidney cancer. I've been asked to share with you today the approach for the first-line treatment of patients who develop metastatic or spread clear cell renal cell carcinoma. sometimes the best way to approach these presentations is to discuss a typical patient that might present with this problem. So here is a typical patient that might come into my office at Rush. In this case, the patient's performance status was 90%. 100% basically represents a completely healthy person with no symptoms from their cancer and perfectly functional. The patient's blood count was slightly low with a hemoglobin measure of 11.1, meaning she was slightly anemic. However, several other laboratory parameters like her blood calcium, her white blood cell count, neutrophils, as well as her platelets were all within normal limits. So all of those data points that I presented are points that your physician would gather because one of the most important tools that a medical oncologist uses to help select the optimum treatment approach for a given patient is to assess what's known as their IMDC risk score. The IMDC stands for the International Metastatic Kidney Cancer Database Consortium model. It's been developed over probably a decade based on thousands of patients with metastatic kidney cancer. This is an example of the calculator, which is available online as a web-based tool, but most of the medical oncologists who see kidney cancer really have these data points committed to memory. So it's a relatively straightforward use to apply the tool. Illustrated here are the patient we just discussed, showing the individual features. Patients are either identified as having a particular feature, yes, or not a particular feature, no. And at the end of the clicking of the boxes on this tool, you can see that the patient identified for first-line treatment as an intermediate risk patient. Now, this tool provides an average survival time for such a patient, but the reality is currently the medians are defined, but the spectrum of survival, it can be quite broad. So this is by no means a specific indicator of life expectancy. Now, the other thing your practitioner might refer to is the NCCN guidelines. That stands for the National Comprehensive Cancer Center Network. This is a group of hospitals across the country that have a number of individuals who make up panels that provide guidelines or recommendations for practitioners for the management of various cancers. This is the kidney cancer sort of tool. And the way individuals use this is they identify, for example, the first line of treatment, meaning the patient has not had prior drug therapy for their cancer in this case. And then you can see that there's a category of risk. And in this case, the patient we just discussed was an intermediate risk patient. And it provides a number of different regimens that can be chosen. In the NCCN terminology, category 1 means there's been a large randomized clinical trial supporting the use of that combination over a control group. So you can see that there are literally 4 different category 1 recommendations for first-line treatment. So your individual practitioner might recommend one of those to you, but a patient later in the day, he might see and recommend a slightly different regimen. And the choice of regimens is often driven by subtle factors, clinical factors about the patient, but they may also be driven by features of the other medical problems that patient may have, and even things such as expertise of the practitioner with one of the particular regimens, perhaps. So I want to run through those different trials that were shown there as choices. And I don't mean for this to be an extensive memory. I just want to illustrate the thought processes that your medical oncologist might run through with you in the exam room as he's discussing treatment. So this was one of the trials that was shown. It's a large randomized phase 3 clinical trial. You'll notice that the control arm, arm B, is a drug called sunitinib. It's an oral agent. It's been approved for kidney cancer for many years, and it actually served as the control arm in many of the clinical trials that I'm going to show you here in the next few minutes. The treatment arm in this trial was a combination of two drugs that stimulate the immune system, a drug called nivolumab and a drug called ipilimumab. And this is a common regimen frequently used in kidney cancer. And the group of patients that were included in this trial included patients from all over the world. They all had clear cell renal cell carcinoma and were all treatment naive otherwise. And all of these trials, you'll notice, include what's called a primary endpoint. And that just means what the outcome was that was agreed to with the Food and Drug Administration prior to the start of the trial, which would suggest that a new treatment was beneficial compared to an old treatment. And here are some of the endpoints in this trial. So you'll notice that these were intermediate and poor risk patients, just like the patient we just discussed. And you'll notice that the red arm is the immunotherapy arm, and the black curve is the control arm of sunitinib. And you can obviously see that there's a wide separation in both overall survival, meaning years of life, as well as time to progression, meaning patients were treated until they developed a relapse. Importantly, you'll notice that on the right-hand curve, nearly 30% of patients out over 5 years appear to remain disease-free, and many of those patients are likely cured of their kidney cancer. Overall survival is even better because some of the patients who relapse can be salvaged, but you can see that at 5 years, nearly 43% of patients were alive with the immunotherapy. So this was very encouraging and clearly better than the established drug sunitinib, and thus this is one of the drugs that's approved. Now, when your physician chooses a therapy, he's not just thinking about the benefits of therapy. Obviously, that's important, but he also wants to think about side effects. And side effects with any regimen are common and frequent. As a matter of fact, one of the ways your doctor thinks about side effects is sort of all of the patients who are going to get a specific side effect. And in this case, for example, diarrhea is shown. Patients in the control group, nearly 50% of the patients had diarrhea. Now, diarrhea can be very mild or it can be quite severe. So the other way physicians think about this is the severe cases are often coded as what's called grade 3 or 4 toxicity. So in this kind of what's known as a tornado plot, the total spectrum of toxicity is shown. So for diarrhea, there was 50% in the control arm, the sunitinib, versus 28% in the nivolumab plus ipilimumab arm. When you look, however, at the severe cases, many fewer patients experience severe diarrhea, only about 6% in sunitinib versus about 4% in the control arm. And you'll notice that for different side effects, it may be more predominant in the sunitinib group, or it may be more predominant in the experimental arm. And again, the physician will weigh the risks as well as the benefits when they make treatment recommendations for you. This is another study that was included in that NCCN recommendation. This was a study comparing a drug called pembrolizumab, which is a form of immunotherapy, plus a drug called axitinib, which is similar to sunitinib, was developed a little bit later in development than sunitinib was. And again, a large randomized trial, similar patient population, similar global enrollment, comparing the two treatment arms. And again, overall survival and progression-free survival were both considered as important endpoints in this trial. Here is an illustration of the outcomes. Again, the pembrolizumab plus axitinib arm is shown in green. The control arm is shown in purple in this slide. And you'll notice that at a number of different what are known as landmarks, 18 months, 30 months, 36 months in this trial, the percentage of patients who were alive compared to the sunitinib all favored the experimental arm. And another way of measuring this is to include essentially sort of the shapes of the whole curve. And if you do that, you can generate what's known as a hazard ratio, which is illustrated here. The hazard ratio is 0.73. So that can be rephrased to suggest that there is about a 37% improvement in overall survival if you receive the experimental combination treatment versus the single agent. Similarly, here is shown progression-free survival. So this is the percent of patients who are relapsing. And you'll notice that at 3 years, about 30% of patients remain without relapse with the experimental arm, nearly twice as many as remain disease-free in the sunitinib arm. And again, the hazard ratio would suggest there's about a 32% reduction in the risk of recurrence if you get the experimental therapy. Another thing that your doctor may think about is what's called a response rate. And response rates are important because that means rates of tumor shrinkage. And if a tumor is large, it can often be causing symptoms. And therefore, by treating a tumor and shrinking it, the symptoms may improve. So responses are a good thing. A CR stands for complete response, meaning there's no evidence of disease left on an individual patient's scans. And you'll see that about 10% of patients had a complete remission versus 3.5% with sunitinib. And a partial remission means at least 50% or more tumor shrinkage, but not quite a complete remission. And you can see about 50% of patients with the combination had a partial response versus 36% with sunitinib. So again, the response rates clearly favored the combination arm in this trial. Here's another example of the tornado plot trying to illustrate for you common toxicities. And again, you'll notice on the left side, diarrhea is common. Drugs like axitinib and sunitinib cause hypertension at a fairly high rate. So when you include a drug like axitinib in the combination, you'll see that high blood pressure can be an exacerbating feature. Some patients develop some injury to their liver, so that there are some blood tests like your liver function test, which can be abnormal. And an interesting side effect with these agents is patients' voices may become somewhat thready from treatment, and that's known as dysphonia. And that was a little more common, for example, in the combination arm. When you look at the deaths that were attributed to treatment, you can see that they were rare in both arms, but actually even with combination therapy, perhaps slightly less than in the sunitinib arm. And if you look at those severe toxicities, the grade 3s, 4s, and 5s, again, there was a relatively good balance, suggesting that there's enhanced benefit, although toxicity can be common with these regimens. This is another combination treatment which involves both an immunotherapy drug, nivolumab, with a targeted drug like sunitinib, in this case, a drug called cabozantinib. This was, again, a global trial, clear cell patients, first-line treatment. Primary endpoint in this large randomized trial was progression-free survival. And you can see, again, the blue arm representing the combination treatment, significantly better than the control arm with the sunitinib treatment. And you can see that there's nearly a doubling in the time to relapse on it for by 50% of the patients, the median PFS of about 16.5 versus 8 in the sunitinib arm. At 2 years, again, 40% of patients were disease-free or were progression-free without relapse versus about 20% with the sunitinib arm. Overall survival also favored the combination here. The hazard ratio, again, suggesting about a 30% reduction in the risk of death if one was treated with the combination arm over sunitinib. Again, response rates were higher in the control combination arm here, 55.7 versus 28.4. And again, more complete responders, importantly, in the control, in the combination arm versus the control arm. And again, toxicity in the tornado plot, common typical toxicities with all these regimens: diarrhea, hypertension, and the liver tests, the voice changes, overall relatively balanced, however, in terms of the grade 3 toxicities, although slightly greater in the combination arm shown here. And the last of the trials that were included in that category 1 recommendations was this trial. This is the most recently concluded trial. It includes, again, a targeted agent called lenvatinib, which is more recently developed, with an immunotherapy drug, pembrolizumab. Again, global trial, clear cell kidney cancer are previously untreated. This was a 3-arm trial, however, including the combination of the 2 drugs, a control arm of sunitinib, just like the other trials, and a 3rd arm of lenvatinib plus a drug called everolimus, which is another oral agent. That regimen has also been shown to be effective in the 2nd line or relapse setting, and in this trial, it was tested in the 1st line setting. And here are the 3 curves. The top line represents the lenvatinib pembrolizumab. The bottom line represents the sunitinib. And if you compare the combination of the immunotherapy and the targeted agent to the sunitinib, you had a striking nearly 60% reduction in the risk of death during the study period. Clearly one of the best numbers we've ever seen compared to that sunitinib. When one looks at the longer-term follow-up, which was just published recently, one can see that the curves do begin to come together a little bit later in the course of this disease. But again, there's very few patients who are out at 4 years. You can see the numbers underneath the x-axis represent the number of patients who've reached those time points. And you can see there's only literally 2 or 3 patients at each of those time points. So the numbers are very small. But when one looks at the shape of the entire curve here with longer term follow-up, there's about a 30% reduction in risk. Here are the response rates: a complete remission rate of 16% with the lenvatinib and the pembrolizumab versus only 4% with the sunitinib. So also a strikingly good complete remission rate. This slide represents the number of patients with greater than grade 3 toxicity, illustrated in the 3rd line from the top. And you'll notice that about 70% of patients developed grade 3 or worse toxicity here. So perhaps slightly more side effects to balance the slightly greater efficacy with this regimen. And here's the tornado plot illustrating those same typical regimen side effects: diarrhea, hypertension, liver changes, some decreased appetite and fatigue, quite common with every one of these regimens. So here are the 4 regimens that we just talked about. And unfortunately, you'll notice that none of these regimens were compared to each other. They were all compared to sunitinib, which makes the choice of this regimen a little bit difficult for practitioners. It's really not fair to say that one regimen is better because its numbers in its own trial were slightly better than another group of patients, because the mix of patients in these trials can be quite different. For example, you'll notice that in the ipilimumab nivolumab trial on the left, 23% of patients fall into what's known as a favorable risk group, whereas in the lenvatinib pembro trial, 31% of patients fell into that same group, and only 9% in the lenvatinib pembro were in the poor risk group, compared to nearly twice as many in both the ipilimumab nivolumab trial and the cabo-nivo. So doing kind of cross-study comparisons is truly unfair. This trial or this slide does try to show you common points that were measured in each of the trials to try to give a flavor of comparison. But one has to be very careful with these kinds of comparisons, and individualizing patient care is probably the most critical point. Again, when one looks at toxicity across these trials, it does become difficult to suggest that one regimen is either less toxic or one regimen is more toxic, again, because of the different makeup in these clinical trials. Now, just to illustrate before we close, another patient, this is a 61-year-old male with metastatic kidney cancer. He's undergone previous surgery to remove his kidney and his adrenal gland. And 4 years later, he develops a recurrence in his lungs. Biopsy confirms that it's kidney cancer that's returned. This patient actually, because of the length of time it took for his cancer to come back, because of his normal laboratories, falls into what's known as a favorable risk group. And you'll notice that in the second bullet, the patient was not treated immediately. The patient had a very slow rate of growth of his tumors, and therefore the patient and the physician elected to just follow the patient with intermittent CAT scans so that the patient had no toxicity because he wasn't being treated with drugs, and therefore had a period of time when he felt quite well despite his metastatic disease. However, typically in these patients, over a few years, their disease continues to slowly grow, and often a patient and a physician will decide that the time has come to receive treatment. Here again is that risk calculator, which shows a favorable risk categorization, and you'll notice that the average survival is almost 4 years for this group of patients. Now, this is the NCCN guidelines illustrating the favorable risk selections, but you will notice that they don't include surveillance. Surveillance is listed on the far right under useful in certain circumstances. But I think that actually a significant percentage of patients who fall into this category, who have an experienced oncologist who sees a lot of patients with kidney cancer, is well aware of that being a very reasonable recommendation, especially in perhaps an older patient or a frail patient. Otherwise, you'll notice that the same regimens that were in the intermediate group are in this group as well, with the exception that the combination immunotherapy arm was not shown to be a benefit for favorable risk patients. So it is not generally included in the preferred regimen category. I'm not going to run through those points again, but these are the same trials that I just showed you. And again, this table illustrates the outcomes for the favorable risk patients. And you'll notice that it looks at, compared to the sunitinib, in only favorable risk patients. So the ipilimumab nivolumab trial of 2 immunotherapy drugs, the hazard ratio for overall survival was 0.94, meaning there was only about a 5% difference by getting the combination therapy, which has greater risk of toxicity than getting the single agent oral drug. So that's why this drug combination is not included in that trial. And even when you look at the regimens that were included, for example, the axitinib plus pembrolizumab, the overall survival was essentially the same, or actually slightly better in the single agent control arm, similar to the findings in the lenvatinib pembrolizumab arm. So one needs to be very thoughtful when selecting these regimens for favorable risk patients, because they can do quite well with either just a single drug, which is administered, or they can be actively followed and monitored closely with no drug treatment. So this group of patients should be carefully managed, ideally by someone skilled in the management of kidney cancer. Before we close, there's a number of side effects that are common with these regimens across each one. I mentioned diarrhea previously. There are a number of tools that your medical oncology team might utilize to help manage such side effects. It depends a little bit on the severity on the left side, and then these algorithms perhaps help guide the practitioner in terms of the approach to managing. Do they stop one drug? Do they stop two drugs? Do you need supportive care drugs? So this is diarrhea. Similarly, inflammation of the liver is common with these drugs, and one needs to know how to appropriately manage it. So there are algorithms, again, available to help practitioners manage this. And here's fatigue, a common side effect with these regimens for patients, and it gives guidance. So when you reach out to your team regarding side effect management, they aren't just winging it or responding off the cuff. Often the team is skilled in knowing how to use these tools, and they've often used them so frequently they actually don't even need to refer back to them. But these are the kinds of tools that are available to help manage the side effects with these agents. I'd like to thank you all for your attention today. I'm looking forward to any of your questions at the panel discussion that we plan to participate in later in the day. Thank you again for attending. I hope it was beneficial.
Good morning, and thank you for joining me today for this session. My name is Dr. Alan Tam. I am assistant professor here at Rush University Medical Center in Chicago. I'm also the director of genitourinary medical oncology. I also serve as a leadership position for the Alliance for Clinical Trials in Oncology. Today, I'm going to be discussing adjuvant therapy and subsequent treatment strategies for advanced kidney cancer. Okay, so earlier today, you had heard about first-line systemic treatment options for advanced kidney cancer, and I'm going to be focusing on adjuvant therapy first. Adjuvant therapy is basically systemic treatment that we give after surgery. We're going to then touch on the role of cytoreductive nephrectomy. I'll explain what that means when we get to it. And then after that, we're going to be talking about second-line therapies and beyond that for patients that don't respond long enough to first-line therapies. And then we're going to also discuss some future research targets and combinations that might be out there in the future. So let's first start with a case. This is a patient that I saw recently. He's a young man, 40-year-old man with hematuria, what we call bloody urine. And as you can see here on this CT scan, this is quite a large kidney mass. It actually measured 15.5 centimeters in dimension when the surgeon took the tumor out. And as you can see from the pathology report here, this is called renal cell carcinoma, clear cell type with focal sarcomatoid features. And clear cell kidney cancer is the most common type of kidney cancer. And sarcomatoid is an aggressive feature, but we now have immunotherapies available that can work well in this population. But first of all, this is a young man, 40 years old with advanced kidney cancer. I would be concerned also that this patient has a more rare subtype, or maybe even ask about family history, perhaps referring for genetic counseling as well, because there are some familial type kidney cancers and what's called translocation kidney cancer that might be treated a little bit differently. But eventually this patient did have surgery, and it was a high-risk cancer. It was invading the ureter and the kidney pelvis. And as far as staging, we call it a T3B tumor. So this is a more advanced cancer. And with adjuvant RCC, or kidney cancer, a third of patients will develop recurrence after they have that primary surgery. And the standard of care in the past has been surveillance alone, because we really haven't had anything that was very effective. We've tried different types of immunotherapies like cytokines and targeted therapy, and we really just couldn't get any improvements in survival or disease-free survival. So a new generation of adjuvant trials began in 2006. And as you could imagine, clinical trials take a long time to result out. And as you can see here, we're usually talking about higher risk patients, usually at least stage 2 or greater than 7 centimeters, that are going to be enrolled in these typical clinical trials. So back almost 10 years ago, a study called STRAC resulted out looking at one of the targeted pills or tyrosine kinase inhibitors called sunitinib. And they compared this to placebo. And this actually did meet its primary endpoint for disease-free survival. As you can see here, there is a clear separation of curve compared to placebo. But the NCCN guidelines is a set of guidelines that we experts come to a consensus to agree upon what should be the standard of care in patients. And so it only got a grade 3 recommendation because there is controversy as whether this is really truly beneficial, because an overall survival benefit was not seen. The curves were overlapping when you look at the overall survival. And when we're talking about curing patients, maybe that's really what we need to be looking at. Furthermore, adverse events, grade 3 adverse events in almost 50% of patients, and grade 4 in 12%. A lot of us don't think the toxicity is worth that disease-free survival benefit. So a lot of people that treat kidney cancer have not really adopted this approach. And furthermore, other phase 3 trials looking at the same type of combination or same type of targeted therapies were really negative for this type of benefit. So this is a meme that I made looking at immunotherapy combinations are really the in thing right now. And as a geomedical oncologist, we're really trying to build upon immunotherapy, and we're trying to step away from what we were doing in maybe the 2000s, where we're using only targeted therapy and maybe a class of pills called mTOR inhibitors or cytokines. So I want to introduce a concept based on this Keynote 564 study led by Dr. Tony Choueiri at Dana-Farber, where they looked at giving these patients a modern-day PD-1 inhibitor immunotherapies. You may know the drug Keytruda or pembrolizumab, and this was given for a whole year. And the other patients that didn't get Keytruda got placebo every 3 weeks for a full year. So these are, high-risk patients that are at a higher risk of recurrence, and they wanted to reduce the risk of developing metastatic disease in the future. And what they showed was that it did meet its primary endpoint of disease-free survival. And at 30 months follow-up, you see a clear separation of the curve. At 24 months here, 78% versus 67% recurrence here. And this was statistically significant. So this made a big splash in the genitourinary community. Overall survival data is not mature yet. Well, what I will say is at 30 months, there looks like there may be starting a separation on the curve. So we think there may be overall survival benefit, but since these patients tend to live a lot longer, we think that we need longer term follow-up to really see if there is that true benefit. And I imagine some investigators and some treating physicians may be waiting for that overall survival signal to offer this to their patient. One thing to consider, though, is although pembrolizumab and these modern-day immunotherapies can be well tolerated, a lot of these patients are probably cured with surgery alone. So how do we really tease out the patients that need this therapy? We don't really have great, what we call biomarkers or tests to tell if one patient has disease that we can't see. There's tests such as circulating tumor DNA that can be investigated, but in this type of cancer, it doesn't really shed a lot of DNA. So we really don't have a great biomarker. And the types of toxicities that we see with immune checkpoint inhibitors, even though it doesn't happen in the majority of patients, there is a significant amount of toxicity. This here is all grades of hyperthyroidism and hypothyroidism. This is immune-related pneumonitis, type 1 diabetes, colitis, although very small amounts, these can be life-altering. Some of these can be permanent too. So one needs to really weigh the benefits and risks when talking with patients as to whether or not they should undergo a year of this therapy when they could potentially be cured. And so there's been several other modern day adjuvant trials, and recently we got updates on these 3 trials, which were negative. And this is modern day immunotherapies. This is something like Opdivo and Yervoy, Ipi and Nivo for 6 months was negative for their primary endpoint. So is there something unique about pembrolizumab? We don't know this right now, but it's actually quite discouraging that we really can't find something else that's more efficacious in the adjuvant setting for kidney cancer. So now let's talk about another case scenario. This is a patient of mine that I treated in 2018. He presented with coughing of blood, hemoptysis. And as you can see here, if you pay attention to the top right corner, you see his CT scan of his chest, just a lot of high burden pulmonary or lung metastasis. So at face value, one may think this is really bad. And he does have a large left kidney mass as well. This was proven to be metastatic clear cell kidney cancer. We do some of these other biomarkers like PD-L1, et cetera, genomic testing, such as we had here. We really don't have any genomics or biomarkers that correlate with better response like we do with other cancers like lung cancer. Kidney cancer just doesn't follow that rule for some reason. Well, most kidney cancers, especially clear cell kidney cancer, do have this mutation called VHL, von Hippel-Lindau mutation. This doesn't mean that they have von Hippel-Lindau syndrome per se. This is just the pathogenesis of how kidney cancer develops. But just so you know, we're doing a lot of genomic testing these days, and it's helping us better understand where we are now and where we need to be. And so this patient, I elected to give him the combination of ipilimumab and nivolumab, or Opdivo Yervoy. This is based on the checkpoint 214 data that you heard from Dr. Kuzel. And this patient was considered intermediate risk based on his IMDC risk factors. And as you can see here, his lungs cleared out of the cancer relatively quickly, within 3 to 6 months. And so I would say that's a profound response. I would argue that this is a patient that might be cured from metastatic kidney cancer with immunotherapy. We couldn't say that in the last decade. His left kidney mass shrunk significantly, and then he went on to have cytoreductive nephrectomy. He had surgery to remove the remaining tumor of his left kidney. And that's, I think, where we need to be. What is the role of cytoreductive nephrectomy today? And, this is something that I put on Twitter, is basically talking about what we think of doing kidney surgery at diagnosis when the patient has widespread metastasis. We really should not be doing that anymore. Back 20 years ago, we were doing that because it was showing a survival benefit. But a recent study called the Carminas really looked at how this translates in the modern age. And this was technically not even that modern, because we're looking at still tyrosine kinase inhibitors only, called sunitinib. But as you can see here, 20 years ago, back when we were doing upfront nephrectomies as a standard of care, we did this because it showed a survival benefit. But the Carmina data now tells us that we should not be doing that for most patients, because we could actually be harming them. Starting with treatment first may make more sense. As you can see, the survival for nephrectomy up front on the right side is inferior. And so what's the rationale for actually starting immunotherapy first and then maybe talking about doing surgery later? Well, there's several reasons, but in general, the cancers have what we call neoantigens. And if you leave the tumor in place, there's a thought process that you have more tumor for the T cells of your immune system to learn, and how to learn them over time to have long-lasting effects on it even after the treatment has stopped. You can also see how the patient is responding with CAT scans while they're on therapy. So decreasing in the kidney size or the other tumor size may be a benefit. Maybe you could even spare the full nephrectomy, if you can downstage the tumor, you can do a partial nephrectomy as well. So we now have a clinical trial called the PROBE study, or SWOG is a cooperative group, and this is SWOG 1931, and we're looking at patients with modern day immunotherapy combinations, whether it's ipi, nivo, pembrolizumab plus axitinib, or lenvatinib, or even cabozantinib plus nivolumab. And these patients would either go on to get nephrectomy later, or they just continue their systemic therapy. Either way, both arms will continue their systemic therapy, and we're hoping that we may see improved outcomes in patients that do have delayed nephrectomy. So now let's talk about second-line therapy. Once again, I apologize for the meme, but how can we overcome primary resistance to patients that are due to relapse or have acquired resistance, right? When you saw the data that Dr. Kuzel presented, you saw that a lot of patients respond to these therapies, but eventually a lot of them will progress or their treatment stops working. So one should not panic. The first study I would like to present is a smaller study, but it's one of many studies that have tested stereotactic body radiation therapy in patients that have what we call oligoprogression. Basically, what this means is you're on systemic therapy and you have mild increase of tumor volume, maybe up to 5 sites of disease that are growing slowly, not too aggressively. Most of the time, these patients are not having new symptoms. And the thought process is that this newer targeted radiation therapy is very well tolerated, and you can cherry pick, per se, individual lesions that might be growing, and with SBRT having high rates of local control, about 90% with minimal toxicity, maybe this can help the patient stay on that same immunotherapy for much longer. And so this study did demonstrate that SBRT can more than double the time on patients on first-line therapy in many patients with oligoprogressive kidney cancer. So this is something to consider before changing lines of therapy. So when people ask, what would you use next? Well, it's really complicated because we have so many new advances in the past 5 years. And, Dr. Kuzel talked to you about all these major immunotherapy combinations, which are the new standard of care. But I will say, in general, it depends on what you got before. So let's say if you had ipilimumab and nivolumab in frontline, well, in the second-line setting, you could consider using something like cabozantinib, maybe even cabo plus nivolumab. Although this is not an approved combination, there is a clinical trial called the Pedigree study that we're running with the Alliance for Clinical Trials in Oncology that is studying an adaptive approach there. But if a patient maybe already had cabo nivo in the frontline setting, or now there's another study that's going to result out soon using a triplet looking at cabo ipi nivo, then your options are less abundant, right? So you try to switch the mechanism of action up and see what the patient didn't have. In that case, it would probably be something like lenvatinib or everolimus. And so, but a lot of us still consider the doublet of immunotherapy with ipi and nivo as a gold standard because it really has durable remissions and the longest follow-up. It also does not have the toxicity of these pills called tyrosine kinase inhibitors. So quality of life might actually be better. If you lose the opportunity to use ipi-nivo up front, then we don't really have great responses in the subsequent settings. We have several trials that show modest responses and very few complete responses if you try to use this combination in subsequent therapy. So that's something to consider. A lot of us and a lot of insurance companies do not agree with using an immunotherapy combination once you've already progressed on one immunotherapy combination, right? Although there is a smaller study that looked at lenvatinib plus pembrolizumab, even in patients that already had immunotherapy and they progressed on it. This was actually quite impressive, 55% response rates in these patients that were refractory to one immunotherapy combination and were able to overcome that, although there were no complete responses in this study. Another option in the third line setting, I would say, is a drug called tivozanib. You know, this is another tyrosine kinase inhibitor that they can compare to a control arm of sorafenib, which is, you know, an older drug that we used maybe in the earlier 2000s. But this is a good control arm because there is no real standard of care in this setting. And so it did meet its primary endpoint of progression-free survival, and tivozanib extended progression-free survival by about a couple of months, a little bit over a couple of months here. And this is maintained throughout now 48 months of follow-up. The final disease state or drug target I wanted to talk about is a new drug that targets the VHL pathway per se. And VHL, once again, is von Hippel-Lindau syndrome. A lot of times this is seen in younger patients, but these patients often have multiple symptomatic tumors elsewhere, either in the central nervous system, the eyes, the pancreas, kidney cysts, etc. So these patients require something to relieve themselves of these symptoms of this devastating disease. And so belzutifan is a new drug that targets this pathway, the VHL pathway, and it targets a molecule called HIF2 alpha, and it binds in this HIF2 alpha molecule, so it can't dimerize or combine with VHL and prevents the dimerization with HIF1 beta, so you don't have this continued signal to the nucleus of the cell to make the kidney cancer grow. And so what we've seen in patients that have von Hippel-Lindau disease is impressive objective responses, not only in their kidney tumors, but elsewhere. This is what we call a waterfall plot. As you can see, the majority of patients are benefiting. 30% is the cutoff for what we call a response, but as you can see, all these patients are benefiting in some way. And another interesting caveat here is a lot of these patients do require, you know, procedures to, you know, whether it's their ocular procedures, laser surgery for their eyes, etc. For all of these VHL-related tumors, they needed some kind of surgery or other procedures. After they started belzutifan, the number of procedures plummeted drastically. So how does this translate into patients that have regular clear cell kidney cancer that's not related to von Hippel-Lindau disease? Well, still great benefit. Objective response rate was 25%, but more importantly, in my opinion, the disease control rate was much higher, anywhere from 80 to 92%, depending on your IMDC risk group. So finally, I wanted to end with a little discussion. One of my areas of interest is the human microbiome. You may be hearing a lot in the news that the gut microbiome, where we have hundreds of trillions of different microbes. And it's important for us to take care of our gut, what we eat, what we put into our body, minimize antibiotic use, etc., hormones, etc. And the reason is that there's a lot of emerging research that says that dysregulation of the gut microbiome can have implications not only on our risk for cancer, but our mental health, our metabolic health. And so there's a lot of research going on here, and this melanoma and kidney cancer and lung cancer, there's been a lot of links between the gut microbiome and the good bacteria balance versus the bad bacteria balance, and how patients respond and how much toxicity they might have from their immune checkpoint inhibitors, their immunotherapies. So this is a very interesting area. There's different modalities to try to modulate this process. There's, perhaps doing a fecal microbiome transplant from one responder to a non-responder. Of course, there are some risks involved with that. Administration of supplements like prebiotics might be of interest. Prebiotics is kind of just like the food or the fiber that feeds the healthy gut bacteria. There's a lot of controversy of taking microbial consortia like probiotics. One would think that might be a good thing, but there are some studies that show that it might be a bad thing because you're not diversifying the gut microbiome enough if you're taking the same probiotics every day. And antibiotics may be detrimental to good bacteria, but there may be some antibiotics that might be good as far as selecting out good populations. So Jen Wargo at MD Anderson has been a pioneer in this space, and she also recently reported that high fiber diet was associated with improved survival and treatment response in patients with melanoma. And in melanoma, kidney cancer and melanoma, in my opinion, a lot of times the research goes hand in hand. And so I consider them close cousins, at least with how we treat and how we respond to immunotherapy. This is a picture of my son who just turned 4, but when he was an infant, I put this slide up here because there was some research back then about short chain fatty acid being a key component of good gut health. And infants seem to have a lot of this short chain fatty acids. So should we be trying to have a gut microbial composition more like infants? Finally, the last study I wanted to mention is this new consortia agent called CBM588 that has just been recently studied by Dr. Monty Paul and his colleagues at City of Hope, looking at a live biotherapeutic product and that promotes butyrate and other short chain fatty acids and has some type of immunomodulatory activity. And what they showed was that when treating patients with advanced kidney cancer in combination with this agent, it did, it was a small study, but it did show improved benefit when combining it with immunotherapy combination, at least ipi-nivo. So more to come on this, hopefully, in the future. And with that, I'm going to stop right here. And I thank you for your time and joining me and hearing about adjuvant kidney cancer and subsequent therapy. Thanks, and have a good rest of your day.
Hello, I'm Dr. Teresa Deshields. I'm a psychologist and the Director of Supportive Oncology at the Rush University Cancer Center in Chicago. I am happy to be speaking today at the Judy Nicholson Kidney Cancer Symposium, a celebration of hope. Let's get started. As you can see, I'm going to be talking today about coping and resilience and survivorship. And this is a little bit different than the other topics that you've gotten in today's presentation. I hope you'll find it enjoyable. So let's talk first of all about who is a survivor, if we're talking about survivorship. In January 2022, it was estimated there were 18.1 million cancer survivors in the US, a really large group of individuals. And of course, that group will just continue to grow. When we talk about who is a survivor, I'm going to just briefly look at historical definitions. First definition was that you needed to be 5 years after your diagnosis to be considered a survivor. That was a pretty stringent criterion. And we moved away from that to a later definition of that you were a survivor anytime you had finished treatment. So as soon as you had finished treatment, you became a survivor. Now, the most current definition, and the one that's pretty widely accepted, is the definition that I have on this slide. You're a survivor from the first breath you take after learning your diagnosis. And this is the definition of survivorship that is favored by the National Cancer Institute. What about caregivers or caregiver survivors also? Actually, the National Coalition of Cancer Survivorship does consider caregivers to be survivors. That hasn't really caught on. It's not so prevalent to hear that, but you know, that is endorsed by some. I have a statistic here from the National Cancer Institute in 2019 that over 975,000 adults in the US were caring for someone with cancer as their sole health problem. Now, of course, that number has also only grown since 2019. So I don't know what that number would be today, but a lot of people, and approaching 1 million people who are caring for someone with cancer. And again, this is limiting it to cancer as their sole health problem. So there are certainly people who have cancer in addition to other health problems. So that number would be bigger, including that. Let's talk about distress in cancer. So the question is distress inevitable? Now, distress screening has become prevalent in cancer centers since the 2015 mandate by the American College of Surgeons Commission on Cancer that cancer centers needed to screen for depression regularly. So it's gotten a lot of focus since 2015. And you can see a wide range of statistics about how prevalent distress is, how common it is. You can see numbers ranging from 20% to 52%, which is a really wide range. But that number varies depending on when the data was collected. So were people asked about their distress right after their diagnosis, further along in their experience with cancer, depending on the type of cancer people have, the type or the stage of cancer. There's also some variability depending on the individual. So how old they are, even their gender, whether they're male or female. So a lot of variability in how common distress is. Of course, there are many sources of distress, and from all the categories that I've mentioned here, this is probably something you could fill in yourself about sources of distress. From a physical perspective, there are side effects of treatment, of course. There are also symptoms of the disease, symptoms of other health issues, and even just things like, seasonal symptoms. Some people have really bad allergies. It's things that come and go, or gastrointestinal upset. From an emotional perspective, there's certainly a lot of uncertainty in the cancer realm. What is my next test going to show? Is my cancer going to come back? So a lot of drivers of uncertainty. Anxiety is also quite prevalent in the cancer space, just feeling anxious about what's happening to you. Also, maybe some sadness and some depression at times about how your life has been changed. From a practical perspective, there's the shifting of work and home responsibilities. Maybe you're able to do them as usual, maybe not. Maybe not able to do them at all, and everything in between. So shifting of those responsibilities. There's also the practical things like transportation to and from treatment. There's the financial issues that are kind of rampant in cancer. It's an expensive proposition to be treated for cancer, even if you have good health insurance. From a social perspective, also some drivers of distress. There's the whole question about communication. So who do I tell? How do I tell them? When do I tell them? That can be kind of tough to work through. There's also the question of who can help, who's there for me, who can help me with the practical aspects of this. From a spiritual perspective, just the questions of why did this happen to me? What does this mean? What is this about? Trying to make sense of cancer coming into your life. The question of, is distress pathological? So distress is absolutely not a psychological diagnosis. So it's not pathological from that perspective. And there's a broad range of distress in the cancer space. So there's the normal feelings of anxiety the day of a test or the day you're getting test results, or reactions to learning of a diagnosis, all the way to more prevalent or stronger feelings up until the point of maybe feeling like this is a real crisis, that this is a real disaster that I am experiencing. So that whole range, everything in between, can fall under the category of distress. Now, this slide is about a study that I published this year, looking at distress in cancer patients and cancer caregivers. So these were not pairs. They were not patient caregiver pairs, but we looked at 328 cancer patients and 169 caregivers of individuals with cancer. And what we found is that their distress and their resilience were very, very similar levels. And we're going to talk about resilience in a minute, so you'll know more about that in the next slide. But their level of distress and their resilience were very much the same. Now, the patients had very slightly higher depression and anxiety. And some people might look at the actual scores and say, well, those look pretty similar to me, but they were statistically different. So if one is higher in the depression and anxiety realm, it was the patients. So I promised we'd talk about resilience. Let's go there. What is resilience? So in its most common definition, resilience is bouncing back. So what it means is that you're impacted by some stressor, some trauma, and it's how you recover from that. The most common form of definition for resilience is that you recover to baseline, recover to where you were when you started. But there's an interesting phenomenon in the cancer survivorship literature looking at something called post-traumatic growth. And what that means is that sometimes people feel like they are improved by going through something difficult, by being tested, that their lives have improved or they have actually improved. And this may come from the idea of learning how strong you are by going through a difficult experience. Maybe you realized how good your support system was by the number of people who showed up. Maybe you took this as an opportunity to reshuffle your priorities, to decide what's most important for you. But anyway, the idea that we can actually be made better or improved by trauma is kind of an interesting one. Now, George Bonanno is a social scientist in New York, and he has done a whole lot of work on resilience in response to different traumas. A little bit in the cancer space, but mainly looking at other life traumas. And he published this graph of different responses after a trauma. And if you're looking at the graph, the higher up you go, the more distress there is. So I'm going to start at the bottom of the graph. If you're looking at it, I'm going to describe it in case you can't see the graph. The very bottom line is called resilience. And this is the person who's generally hanging in there. They're doing okay despite this trauma. So over time, they are pretty much functioning normally. Above that, there's the delayed response. And this is the person who does okay immediately after. They're kind of putting one foot in front of the other and just doing their best to get through the situation. And then after the fact, they are more impacted by it. Like, oh my gosh, what happened? And as they realize the fallout from their experience, they have more distress or trauma. So that's the delayed trajectory. The third line is the recovery trajectory. And that's people who are kind of first knocked off their feet by the experience, by the trauma or the stressor. And they have a hard time recovering, but they do. So they have a slow, gradual recovery. So they get better over time, but it takes them a little bit. It takes them a little bit to regain their footing. That top line or the last line is the chronic pattern. And this is the person who something happens and they just never recover. They never bounce back. Their lives are changed, and they are adversely affected by it over the long haul. Now, if this were an interactive presentation, I would love to ask you what you think it would be the most common of these responses. And but since it's not, I'm going to just provide the answer. But Dr. Bonanno has demonstrated that the resilience trajectory is the most common. So that resilience pattern is the most common one. The chronic one, so the person who just never quite recovers, is the least common one. But I do want to acknowledge that if you are the person experiencing that type of response, that is a really tough place to be. It's a really tough road to be so adversely affected by something over the long haul. So while it might be the least common, it is certainly the most difficult. So now I'd like to shift the focus and to talk about how to promote resilience, how to grow it. I don't like to talk about challenges without also spending some time talking about how to address them. What are some strategies for addressing those challenges? So the remainder of our slides is going to be talking about how to promote resilience for yourself, whether you're a cancer patient or a caregiver. The very first slide is about self-care. So this is basically that first thing about taking care of yourself physically is really about all the things that your mother told you to do. So turns out she was right. So it's important to eat right. And by eating right, that means eating regularly and eating healthy as best you can. Another way to take care of yourself physically is to get enough sleep. Sleep is so important as your body spends energy on healing. Now, those two things are things that tend to go out the window when we're really stressed, right? We tend to skip meals. We tend to eat fast food or junk food to comfort ourselves. We tend to cut back on our sleep. We tend to stay up too late. We sleep badly. So those two things can be a bit vulnerable. But I encourage you to try to find ways to take care of your physical self as best you can. The second bullet is about finding ways to relax. And there is such a variety about ways to relax. There are very technical relaxation strategies. And then there's also just listening to relaxing music, going outside for a walk. So finding ways to relax is very much individually determined. And I encourage you to find the one that works for you. There are a lot of apps available. If you like to be guided in your relaxation practice, you can find all kinds of apps these days. And several of them are available for free. So not always at a cost. So if you want to be guided or led, and that's certainly possible for you also. And then the being kind to yourself. So I find this in my own practice with cancer patients and caregivers that people tend to be pretty hard on themselves. So very self-critical, and having that inner critic following you around, just whispering in your ear, can be very distressing. So I encourage you to find ways to be kinder to yourself. If it helps to have the frame of thinking about someone who means a lot to you, someone very dear to you, and thinking about how you would talk to them and trying to use that as a frame for how you might talk to yourself. So if you could you could endeavor to be as kind to yourself as you would be to others. Now let's shift to social support. So humans are social creatures. We are born to live in community, to live in groups. Now, COVID certainly challenged that. The COVID pandemic certainly tested that. The gift from COVID is that we found ways to connect virtually. And so if that helps, if you're not close to those you love, or if you're feeling immunocompromised, you can connect virtually. I've also learned from the patients that I've worked with that through a cancer experience, you sometimes you lose contact with people. There's some people who just can't make that journey with you, who cannot be there for you through that experience. But I also hear that sometimes new people step into your life. So new people step up. And so you might find some new social connections that you discover through this experience. The bottom line is just to try to find ways to stay connected with others as best you can. There's been some recent research that says that really helps in terms of your mood and quality of life to have those social connections. So the next step is to try an attitude adjustment. And I have the phrase up here, it is what it is. And this is about trying to look at your situation realistically. Some people have a tendency to look at the worst possible outcome from any situation, maybe as an effort to be prepared for the worst. But they tend to see things in its worst possible form. That's sometimes called catastrophizing. So taking things to its worst version. And that, of course, is very distressing. But there's also the issue of trying to make things better than they are. If you've heard that expression, putting lipstick on a pig, it's like that. You're trying to take a difficult or challenging situation and trying to make it look okay, or trying to make it seem all right. And that can be a lot of effort and work too. So this is about just trying to view a situation as realistically as possible without expending so much energy looking at the worst possible version of it, or trying to make it, trying to pretty it up, trying to make it better than it is. Humor. Humor is always a good thing. I encourage you to find a way to laugh whenever you can. It relieves a lot of tension in yourself to laugh, and it also relieves tension for others. So anytime you can find a way to laugh, that's a good thing. Now, maybe you're naturally funny and this comes to you easily. It may be also that you have funny people in your life and you can rely on them to help you find a way to laugh. If those things aren't available to you, you can always look up jokes online. You can subscribe to a joke service. I believe there's such a thing, I've heard. You can also watch funny movies. So just trying to find opportunities to laugh. Gratitude work. Let's talk about gratitude work. It's having a moment of popularity. And this is about just focusing on the good things that have happened to you. These don't have to be huge successes. They can be little things like the weather was nice today. The sun was out. I got a chance to get outside. I got a chance to sit on my porch. I had a phone call with a friend. It can be small things or big things. But it's the practice of regularly reflecting on those. Many people find it useful to do this at night before they go to bed to review the day and focus on what they're grateful for. That can be actually a great way to go into sleep with that kind of practice. You can just do it mentally, or you can record it in a gratitude journal. Some people like the ability to go back and look at their what they have found to be grateful for on a daily basis. So it's kind of nice to go. It's very uplifting to go back and look through all the different things that you recorded. So that might be an incentive to do that. Our last strategy is about values-based living. And this is about reconnecting to your own values. So what's really important to you? So first, maybe you need to reflect on that, about what's really important, and remind yourself of what your values are. And then to make sure whether that shows up in your life. So what's important to you? Is that a regular part of your life or very much in the background? And so trying to find ways to bring those important activities or things forward, making sure that there's some regular expression of your values in your day-to-day life. Sometimes cancer can just kind of overwhelm things and you might have gotten removed from your values. So this is about reconnecting with those. I'm going to close here with a slide. that has a quote on it. Scientifically, happiness is a choice. It's a choice about where your single processor brain will devote its finite resources as you process the world. Again, thank you so much for joining this presentation. I will be in the question and answer session. If you happen to have any questions, I'm happy to entertain them then. Thank you.
Good afternoon. My name is Sean O'Mahony. I am the Section Director for Palliative Medicine at Rush, and I take care of patients with life-limiting illnesses, both on an outpatient basis and an inpatient basis. So I work extensively with patients and their families. The topic of my talk today is going to be palliative care for patients with renal cell cancer and for their families. Approximately 90 million Americans are living with serious and life-threatening illness, and this number is expected to double over the next 25 years with the aging of the baby boomer generation. Yet studies show that most people who are living with serious illness experience poorly controlled symptoms, fragmented care, gaps in communication with their physicians, and enormous strains on their family caregivers. So what is palliative care? Palliative care is a medical specialty with the goal to prevent and relieve suffering and to support the best quality of life for patients and their families, regardless of the stage of their disease or the need for other therapies. This definition comes from the American Academy of Hospice and Palliative Medicine. It's interdisciplinary. It involves care by doctors, advanced practice providers, social workers, psychologists, chaplains, nurses, support staff, and it's relevant in any chronic illness. Many patients can benefit. It's appropriate for a patient with a serious, stable, complex illness or a patient who has a progressive illness. It's a team-based sport. So for example, our team at Rush constitutes nurses, medical assistants, physicians, social workers, advanced practice nurses, and a clinic coordinator. We can be involved in the care of patients over many years. I've been at Rush for 12 years, and the longest I've cared for a patient at Rush now is 12 years. It may be of benefit across the trajectory of illness, and we work closely with other supported medical services such as psychosocial oncology, psychiatry, psychology, social work. How can palliative care clinicians support patients with renal cell cancer? We can help to manage physical and psychological symptoms related to the cancer or its treatment. We can help our patients and their families coping with their illness. So living with a life-threatening illness is stressful across multiple domains, including psychological stress, familial stress, financial stress, physical symptom burden. And we can help patients develop practical problem-solving solutions to the many problems that they face. We can assist with communication with medical teams about treatment preferences. These conversations are often quite complex and they involve multiple teams, so it can be a difficult conversation for all concerned. We can also support patients and families in their efforts at advanced care planning. Common symptoms that patients encounter with renal cancer include cachexia, which is the loss of appetite and energy and weight loss. In renal cell cancer, it's often accompanied by night sweats, fever, and taste distortion. It can respond to dietary modification, such as having small plates more often than the conventional 3 large meals a day, choosing foods that we might not ordinarily gravitate to, such as bland foods, food that's not too warm or not too cold, avoiding strong smells, when people are cooking can help promote appetite. Sometimes people need to take medications. So medications that can be helpful include progestins, which can promote weight gain. However, it doesn't necessarily promote improvement in lean body mass. And long-term, there is a risk of deep venous thrombosis. Patients with renal cancer are at particular risk of DVT. Short-term dexamethasone can be helpful. Some patients find the use of both medicinal and medication cannabinoids as being helpful with appetite promotion. Anemia is common in patients with renal cell cancer, both due to the disease and its treatment. It may be associated with fatigue or shortness of breath. Sometimes it may respond to erythropoietin-based medications. Occasionally, transfusions may be helpful when there is a need to increase the hematocrit quickly. Patients with renal cell cancer are at risk of hypercalcemia. This can lead to confusion, constipation, sleepiness, and dehydration. It becomes more common in patients with advanced disease. It responds to intravenous hydration and intravenous medications in the bisphosphonate class, such as pamidronate or zoledronate. These medications are often used in patients with osteoporosis. They may also be used in patients who have bone metastases that are painful as well. Pain becomes more common in patients with more advanced disease. In advanced renal cell cancer, as many as 9 out of 10 patients will incur at least daily pain. It responds to many different modalities. So physical therapy and occupational therapy approaches can be very helpful. So connective tissue mobilization techniques such as deep tissue massage or iStem can be helpful. We should check with an oncologist first if patients have low platelets before recommending these interventions, or if people have problems with clotting, as they may be at risk of bleeding. Transcutaneous nerve stimulators can be tried in physical therapy, and if helpful in physical therapy, can be used at home. They deliver very small voltages of electricity, which trick the nervous system into interpreting pain as being less painful. Dry needling can be helpful. Therapeutic ultrasound can be helpful. Heat, aquatherapy, lymphedema dressings can be helpful. So occupational therapists can devise chronic disease management approaches and psychological approaches, including acceptance-based theory approaches. Cognitive behavioral therapy has the most evidence supporting its efficacy as a psychological adjuvant for pain management. Use of mindfulness techniques that may help with pain and other symptoms such as insomnia include relaxation, distraction, guided imagery, and deep breathing. It can help reduce pain by as much as 30%, and as little as 5 minutes a day of this practice can achieve long-term measurable effects. Hypnotherapy has also been proven to be effective for chronic pain management. Art therapy and music therapy can be helpful for procedural pain as well. Pain medications are often used in patients with cancer pain. For mild pain, for people with bone pain, we might use an anti-inflammatory medication or acetaminophen. For patients who have pain related to a nervous process, such as postherpetic neuralgia or pain related to compression of a nerve root as it exits from the spine, we might use an antidepressant medication such as duloxetine, or an anti-seizure medication such as gabapentinoids, such as gabapentin or pregabalin. There are different types of pain. Patients with somatic pain or pain related to A structure such as bone or muscle will describe very well localized, often sharp or throbbing pain. Whereas patients with visceral pain or pain related to organ involvement of an organ such as the bowel or the bladder or the stomach, they might describe their pain as being dull or achy or cramping or poorly localized. A person who's experiencing pain related to injury to a nervous structure can describe their pain as being shock-like, electrical, pulsating, and located in the distribution of a nerve. Opioid medications are indicated when patients have moderate to severe cancer-associated pain. These medications include morphine, oxycodone, buprenorphine, hydromorphone, fentanyl, methadone, codeine, and tramadol, to name a few. They also exist in both long-acting formulations and short-acting formulations. The long-acting formulations are useful in people who have continuous pain that is present all of the time. For breakthrough medication, the preferred approach is the use of short-acting medications, which work for a few hours and have onset of action within 15 to 30 minutes when taken orally or by mouth. Breakthrough pain is often induced by a predictable activity. Unfortunately, opioids have many side effects. In the short term, constipation, which tends to be persistent in about 20 to 40% of patients and may require ongoing use of a laxative medication. Nausea is common in the first 2 weeks that a person starts an opioid medication, and we may need to use an anti-nausea medication initially. Sedation may occur again commonly in the first couple of weeks that we use an opioid medication. It may warrant reduction in the dose of a medication if pain is well controlled, or if pain is poorly controlled, it may warrant rotation to another medication. It can cause itch, it can cause confusion. An opioid use disorder can occur on average in 1 in 10 people who use opioid medications for pain. Longer-term concerns include greater incidence of depressed mood, weakening of bones or osteoporosis. There's an increased incidence of fractures. There may be endocrine abnormalities such as suppression of the hypothalamic pituitary adrenal axis. There may be hypotestosteronism in men, reduced libido, and there's theoretic concerns also about immune suppression. Buprenorphine has become quite commonly used in the last couple of years. It's now becoming the recommended first-line opioid medication by Health and Human Services. It's an atypical opioid insofar as it's a partial mu-opioid agonist. Most other opioids are pure mu-opioid agonists, and it works as a kappa receptor antagonist. There's a lot less tolerance to its effects, so we don't typically need to increase the dose of this medication. It causes less constipation. It's quite effective in conditions where you have central sensitization, so it's effective in neuropathic pain. It's the first-line opioid for elders. It can be very potent when given underneath the tongue or intravenously. For example, 16 milligrams sublingually would be equivalent to 480 milligrams of oral morphine equivalent. So a very strong medication. It's now available as weekly patches or 12-hourly buccal films so that they're applied on the inside of the cheek, or they can be administered underneath the tongue sublingually or intravenously. Advanced care planning is a process that supports adults at any age or stage of health or illness in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to ensure that people receive medical care that is aligned with their values, goals, and preferences. There are extensive online resources for both clinicians and patients to facilitate advanced care planning, and they're available through entities such as Respecting Choices and Prepare for Your Care. So tips for negotiating meetings with medical teams. Decide who in your support team you would like to be there at the meeting when you're meeting with medical clinicians. Write down your questions in advance because it's very easy to be overwhelmed by the medical team, particularly when we come into your room unannounced at a time when you're not expecting us. Ask somebody on your support team to take notes to facilitate recall, because it can be very hard to recall the details of the conversation, particularly where you're talking about difficult topics like a new diagnosis or disease recurrence or progression of disease. Ask for a recap or a summary of what's been discussed at the end. If you don't understand what the medical team is telling you, ask for clarification. If at any time what you're hearing doesn't make sense or you don't agree with what you're being told, please speak up. If a meeting doesn't result in a clear, definitive plan, ask for a follow-up meeting. Surrogate decision-making is particularly important for any adult to have somebody to be a go-to for decision-making, because we never know when we might be not able to talk for ourselves. So if we have chronic medical illnesses, we might acutely become sick due to infection or a metabolic abnormality. So a healthcare power of attorney is a document that formally allows you to designate a surrogate decision maker to act as your voice, and typically there will be a backup person to that surrogate. Most people will pick a family member, other people will have a friend that they trust to be able to make good decisions that reflect their values. It's important that you talk with that person or people to facilitate their ability to make decisions that best reflect your values and your goals. So in conclusion, palliative medicine is a clinical specialty that involves multiple different types of clinician who support the quality of life of patients and their families who are experiencing life-limiting illness. They facilitate shared decision-making by patients, their families, and their medical providers. And palliative medicine can be of benefit at any point in a patient's illness. Thank you very much for attending this talk and this conference. And I look forward to hearing what your questions are and to sharing my knowledge. Hopefully it can answer your questions. Thank you.
Good morning, everyone.
Morning.
Let me be the first to thank our speakers this morning. You all did a great job. So appreciate very much your time and effort today. I believe that we're going to try to do a question and answer session here. So are individuals going to type messages in to the organizers, or are their mics open? What is PPE? PPE usually refers to personal protective equipment that would be utilized if you were examining a patient who has an infectious disease. Obviously, PPE has become very well discussed in the media recently because of COVID, but certainly it might be worn for any number of communicable diseases, infectious diarrhea, as well as respiratory infections. You know what? I'm going to have Dr. Tan take that one. You might be muted, Dr. Tan. Dr. Tan, you're muted. Nope, Still muted. Or you don't have a microphone. Well, while Dr. Tan struggles with his technology, PD-L1 is a protein on the cell surface of all of our cells, both normal as well as malignant cells. PD-L1 is the basic target for our recent immunotherapy drugs, the checkpoint inhibitors. So drugs like pembrolizumab or nivolumab basically interfere with the binding of PD-L1 to its receptor PD-1. The normal binding of PD-L1 to PD-1 results in basically shutting down an immune response. So by interfering with the binding to PD-L1, it allows the T lymphocytes in a patient to be reinvigorated, especially those that are in a tumor microenvironment. And it may allow for a significant response to therapy. So we often quantify PD-L1 on some of our testing before we treat a patient because it may give us a better expectation of likelihood of response to some of our immunotherapy drugs.
Can you guys hear me now?
There you go. I can hear you now, Dr.
Good. Yeah, I like Dr. Kuzel's explanation. But unfortunately, in kidney cancer, it really doesn't mean too much. There's biomarkers like Dr. Kuzel was mentioning. We like doing genomic testing. Right now, it's all exploratory right now. But when we do genomic testing and precision testing, we're talking about next generation sequencing. We look at what kind of mutations are involved in kidney cancer. And in kidney cancer, we usually see things like von Hippel-Lindau mutation or VHL. That doesn't mean that you have von Hippel-Lindau syndrome, but it is one of the drivers in a lot of clear cell kidney cancers. But specifically, other things like tumor mutational burden or PD-L1 are kind of exploratory. But they do mean a lot of things in other cancers, I would say, like bladder cancer that we also treat as well. But in kidney cancer, unfortunately, it's really not too helpful.
So you developed kidney cancer in your transplanted kidney. I think that's the question. Certainly, if a transplanted kidney develops cancer, I guess if it was small kidney cancer, you could consider doing a partial nephrectomy. But given the presence of immunosuppression and whatnot, taking it out might have been the best decision.
Yeah, I agree. If it was small enough to do maybe a robotic partial nephrectomy, that might be the best thing. But removing is probably the best thing. Immunotherapy is quite risky, I would say, when patients are on immunosuppression, and probably might have limited efficacy too when you're suppressing T cells.
Well, in these settings, maybe you can try SBRT, stereotactic body radiation, if it's not big tumor, typically less than 7 cm. We can do SBRT. That probably, if a surgery is not option here. SBRT only talking about typically 3 to 5 fractions. Very easy tolerated based on the results of recent phase 2 trials that showing over 90% control, local control rate, but certainly is a short follow-up time, but certainly is a good option, not invasive.
Yeah, Dr. Wang, I think there's also certainly for very small lesions, there's data regarding radiofrequency ablation, which is basically microwaving of a small tumor. And we do that sometimes for tumors that are in a normal kidney, elderly patients with a small lesion who may be not healthy enough for surgery. So again, it would all be driven by how large the mass is, unfortunately. They have to be pretty small for a sort of a focal technique to be effective.
Yeah, Dr. Kuzel, you're right. There's, options for local mini invasive or non-invasive options for the small tumor, even for renal transplant, but it still should be considered an option there. Thanks.
That's a great discussion question. And Dr. Wang, what if a patient had tumor thrombus into the inferior vena cava? Is that also something that you can control well with SBRT?
I don't think we have lots of data for that. All this SBRT data is for localized renal cancer. But I think it's depending on the tumor, all depending on the size. We don't have good data on that. Most of the times is included in the SBRT treatments. But theoretically, we should be able to control with radiation.
That would be an interesting clinical trial, Dr. Wang, comparing two minimally invasive techniques.
The reason why I ask is there's actually a patient walking to you right now that's 92 years old that I don't think is a candidate for immunotherapy or targeted therapy based on, being asymptomatic, and also it is also a non-clear cell too. It's a type 1 papillary, so I don't feel confident in my systemic therapies anyways. So I think it'd be a great discussion to have in a different setting and in a tumor board that we usually have every 2 weeks.
I actually think that's a great point, Alan. And Dr. O'Mahony, you can comment as well. We're seeing increasingly more and more, not just, I guess, elderly, but sort of super elderly patients. And trying to have an honest discussion about the risks and benefits to a person in their mid-90s regarding, especially a relatively small tumor, often would benefit from having sort of an early adoption of palliative medicine teams or psychosocial teams, because actually they may do just fine with observation, although that can be a very challenging recommendation for patients to try to live with the sort of cancer as opposed to treating it. So trying to help our patients cope with those tough decisions can be a challenge.
Yes, and I think it would be important that those conversations would also include, and clinical evaluations would include an assessment of frailty or subclinical frailty, because elders who have underlying comorbidities may have subclinical frailty, which may be unmasked by cytotoxic therapies. So somebody may have mild cognitive impairment and they get cytotoxic therapy and they develop frank dementia as a result, or neuropathies may be worsened, which can interfere in their ability to ambulate. So things like grip strength, get up and go test would be good things to incorporate into our evaluation, as well as caregiver stress, because if the family is already stressed, then it will become worse if we provide certain treatments.
Good point that you're making, Dr. O'Mahony, just that not all 80-year-olds are the same, right? That there are some young 80-year-olds, some old 80-year-olds. So it's not just age that's the relevant factor, but so many other factors as well that weigh into trying to figure out whether somebody can tolerate treatment toxicity.
I think we had a follow-up question about the kidney transplant issue. She's asking, shouldn't I be able to go back on top of the transplant list? So I think that's, probably up to the transplant team. I think there usually is some criteria of being cancer-free for a set period of time before being eligible for another kidney transplant. I'm not sure if anybody else on the call has any other information on that.
No, that's very true. They actually have fairly strict criteria, and it's not up to an individual transplant center. I think that there are sort of criteria that have been developed nationally regarding who can go on it. And unfortunately, when a patient has had cancer, often it requires a period of time with no recurrence before you can get back on the transplant list. And I used to see a fair number of these patients regarding that question, and I think it's been variably between 2 to 5 years of a disease-free period. So I think you should talk to your transplant surgeons and find out how long they would anticipate needing to be disease-free. Well, it's almost 12 o'clock, and I believe that 12 o'clock was the witching hour for us. So I don't see any more questions. And thus, I'd like to again thank all of the presenters, and I certainly hope that the people in the audience have enjoyed the presentations and they've learned something. And I believe they're going to be archived on the Foundation's website. So if you missed one, if you had to take a bathroom break or something, they will be available subsequently. So thank you again, and have a wonderful weekend, everybody.
Thank you.